Okay. Welcome, everybody. I apologize for the delay, but we had a very good problem, which was we had too many people sign up unexpectedly, so we didn't plan for this great a turnout, so we're delighted that you're all here. It really means a lot to us. We hope this, first of all, I'm Paula Landman. I'm the nurse navigator with the melanoma program.
I'm Trish Long, the nurse practitioner with the melanoma program in surgical oncology.
And our program has blossomed so much that I needed a partner in crime, so this is Melody. Speak up.
Melody Harris.
And she is another nurse navigator with the program. We hope that this afternoon proves to be educational as well as a way to connect with other folks. A couple of housekeeping things. Please feel free to use the facilities at any time. There will be a break in the afternoon as well. We really encourage people to stand up, ask questions. There's a microphone in the middle. Because, you know, the question that you asked may be something that somebody wishes they would have asked or was too shy to ask. We have some celebrities in the audience. We have patients here who have spoken at previous conferences and are doing well and continue to come back to support us. So if those friends could stand up, we can give you a little hello and round of applause. Get up, Janet. Dr. Jackson, Mr. Patterson, Ms. Edmonds, I saw you, Ms. Fuss, Kristen. Very exciting. So we, clearly have made many, many strides in melanoma, but we can still do better. We've unfortunately had quite a few losses recently, and we want to take a moment of silence just to hold those people in our hearts, anybody that you might be thinking about, who's going through difficulties, or anybody that you may have lost in recent past or at any point. So just a moment of silence, please. Thank you. We're going to go a little bit out of order on our agenda because of the delay and people have other obligations. So it's my pleasure to introduce Dr. Laura Ferris. She is the chair of our Department of Dermatology and a key member of our multidisciplinary team here.
And then front, back, and then that's your pointer there.
Okay, great.
Okay.
Thank you so much. So thank you. This is great. This is my second time presenting. Last year I was very new to Chapel Hill. I've been here a little over a year and a half. And it's great to be part of this incredible supportive meeting and to partner with the MRF, who have been partners of mine over the years and are great advocates for patients and supporting research. So I'm going to talk about understanding your new melanoma diagnosis, what your dermatologist wants to know. So, you have a multidisciplinary care team when you're a melanoma patient. So we each have a little different perspectives and a little different areas that we focus on. Okay, so the things I'm going to talk about are how is melanoma diagnosed? I'm going to talk a little bit about what does my pathology report mean. I think that's really important because oftentimes patients see their pathology reports even before we do because they are released immediately. So I spend a lot of time when patients see that and don't know what everything means going over it. What's the next step? What does the future hold? And then how can I protect myself and my family from skin cancer? So, the very basics of melanoma, I think most of you have probably heard about the ABCDs. So, once you've had a melanoma, you're oftentimes looking at your own skin or looking at the skin of your loved ones, trying to, figure out, is this a lesion I need to be worried about? So, over 30 years ago now, we came up with the ABCDs in melanoma, which is A is asymmetry, the two halves don't look the same. B is borders that are irregular. C is colors, meaning multiple colors. Diameter, D is diameter, and I really mean by that like the diameter that's greater than a pencil eraser. Since then, we've added a little bit to the ABCDs. E was the next logical place, and that's evolving or changing. So a lesion that starts out as one thing, but you can notice over time that it's changing is one that your dermatologist should take a look at. And then regression lesion is another one. So that's usually later stage melanomas that become very, they go from being very dark to even white in the center. And then I like the ugly duckling. So we all have different looking nevi. And what's a normal looking mole on me may be an abnormal mole on you, and vice versa. So I always tell my patients, if you have a new mole that appears and it looks just like all your other moles and it's not changing rapidly, I'm generally not terribly concerned about it. But if you get a new mole and that doesn't look like anything else on your body, that's the one that needs a closer look. Okay, so making a melanoma diagnosis can be easy. So I think most people in this room would look at these lesions and say, that's a problem, that needs to be seen, but it can also be more challenging. Sometimes these are very, clinically subtle melanomas on the right side here. And, if I can leave you with one thought, it's that melanoma can have lots of different appearances. So that's why, the ABCDs can be helpful, but they're not gospel. And that's why, sometimes things like the ugly duckling sign can be helpful. Okay, so how do we make a melanoma diagnosis? So a skin, the way that we do this as dermatologists is generally by doing a skin biopsy. And when we talk about biopsy in other cancer areas, sometimes that means we just take a little piece of it just to get a diagnosis. It's a little different with melanoma. So ideally, we actually want to remove the whole lesion when we are making a diagnosis. Now, there's times that is not possible, nor is it practical. So oftentimes what your dermatologist will do is what we call a shave biopsy. I really call this a saucerization biopsy because I'm not just trying to shave off a little piece of it. I'm actually trying to get in and scoop out the entire lesion. We want to see, what we want to see around the edges, and then we want to see the depth of the lesion. And we'll talk a little bit more about your pathology report and why I say that the depth, or what we call the thickness of that lesion, matters. There's other ways that we can do this. Sometimes we do an elliptical excision where we go around the entire lesion and then we put in stitches and sew it up. Sometimes we'll do what we call a punch excision. And so a punch is a little tool that I say looks like a little teeny tiny cookie cutter. It goes directly down into the skin. We really do this when not just to take a little piece of the lesion, but when it's a small enough lesion that we can actually get the whole thing with a little bit of margin of normal skin within the punch tool. Okay, so when you get back your pathology report, you will see that there are tons, it doesn't just say melanoma or not melanoma, there's tons of pieces of information. So one of the first things that will be listed is the melanoma subtype. So we have multiple different subtypes of melanoma. The most common one that we see is superficial spreading melanoma. That is melanoma that we tend to think of as having the best prognosis. That means that it is sort of growing outwards, it's not growing deeper into the skin. There are other more aggressive subtypes, including nodular melanoma. That tends to be one that's growing rapidly, or acral melanoma, which is melanoma occurring on the palms and soles. The next thing that you'll often see is the Breslow thickness, and this is really why I said when we do a biopsy, we're trying to make sure we get around and under the entire lesion. So this tells us how deeply into the skin the pathologist can see melanoma tumor cells. So we know that thinner tumors are associated with a better prognosis. So the best prognosis is in situ or stage 0 melanoma. That is when we just see the melanoma cells sitting at the very top. They are not, going into the dermis, which is the deeper part of the skin. We'll then sometimes break melanoma into thin, intermediate, or thick, so thin we think of as lesions that are less than 1 millimeter thick. Intermediate in the 1 to 4 millimeter thick, and then thick as being thicker than 4 millimeters. Now, we don't just get those three groups. You can have a 0.5 millimeter melanoma, you can have a 1.2 millimeter melanoma. Clark level is something that was used more in previous staging. It is not always reported, but most pathologists still do this. So they will say, this is a Clark level 1, 2, 3, 4, 5. And so this tells us an idea, not just in millimeters of how thick the lesion is, but where in the dermis. And so the reason that matters is if you think about it, the skin of your eyelid is really different in thickness than the skin of your back right? So it also gives us an idea of how far into the different layers of skin the melanoma is going. If I can leave you with one point, Clark level is not disease stage. So I've had patients say, oh my gosh, I saw my report, I have a stage 4 melanoma, but really it was the Clark level 4, which is very different. You can still have a very thin melanoma. So Clark level can be scary if you just look at it and think of it as staging, but it really is very different. Okay, and then ulceration is another parameter that you'll see in there. So ulceration just means the top layer of the skin over the tumor is starting to break down. What does that mean? It generally means that those cells are dividing and growing rapidly, and so you get breakdown of the skin just because the cell proliferation has been so rapid. So that is generally a poorer prognostic factor, so we want to see tumors that are thin and non-ulcerated. Now, why does this all matter? Why do we use this? So, when we do staging, and I'm sure somebody will talk a little bit more about this, but we do something we call TNM staging. So T is the tumor, which is what my focus is on. N is the nodes, and M or the metastases. So in the T staging, we are looking at how thick, so what is the Breslow thickness, or what's that millimeters of thickness, and then is that tumor ulcerated, yes or no? And so we go from T1 to T4. T1 is in situ is, of course, the best prognosis. We see the best outcomes in patients who have T1, and then as you go to T1A, is better. T1B is a little bit worse prognosis, down to T4B, which has the worst prognosis. So what makes those up? It is the Breslow thickness, and then also whether or not the tumor is ulcerated. So this is a graph that we can see. This is looking at the probability of surviving your melanoma, which is on that y-axis, and then the years since diagnosis, which is on that x-axis. So you can see over time, if you're a T1A tumor, which is that top kind of plum-colored line, the survival probability is like 95%, even out to 10 years. That's great. When we get down to that light pink one, which is T4B, where T4B lesions, you can see that the probability of survival out to 10 years is not quite as good. It's maybe 75% on this graph, just looking at tumor thickness alone. So that's why it's important for us to have this information. Okay, next we will get into mitotic rate. So this is something that's not used in staging, but we know it gives us important information. So if you can think back to high school biology, mitosis, dividing cells, right? You can picture those. So we are looking for that. So how many rapidly dividing or visibly dividing cells can we see in a square millimeter of tissue? So more mitoses is worse. We like to see fewer mitoses. Satellite metastases, these are basically pieces of tumor that are broken off from the main tumor, and we can see them sort of in the skin, but not connected to the main tumor. This gives us a higher stage. It's associated with the worst prognosis, so that's why our pathologists are looking for this as well. Tumor infiltrating lymphocytes are not always reported. You're going to hear about some therapies. One of those is actually called TIL therapy, which does stand for tumor infiltrating lymphocytes. So these are your immune cells, and their pathologists will look to say, are there immune cells in there that look like they are attacking that tumor? That's usually a good sign that the immune system is activated against them. And sometimes for more advanced melanomas, we will actually send tumor out or harvest those tumor-infiltrating lymphocytes, grow them up, and give them back to patients. Regression is what I showed you with that in that ABCD slide. It's areas, you could see it clinically or visibly with your naked eye when you see the white areas in the middle of the tumor, but we can also see that under the microscope. It looks like an area of scar where melanoma cells used to be, but where the immune system has already attacked them. And really, you'll just say regression is present or absent. Okay, so why does this matter? You can see here the mitotic rate. So again, in that purple plum is 0 mitoses seen. You can see that the melanoma-specific survival out to 10 years is the best if we have none. And then if we go down to sort of that brownish color, upside-down triangles, that very bottom line, you can see that if patients have 11 or more mitoses per millimeter squared, that's a pretty active tumor, and that is associated with the worst prognosis. And then satellite lesions, we're really looking at either they are present, they are not present, which is that purple line, best prognosis, or they are, which are there are different ways that we measure them, but really they all have the same implications. Okay, and then another thing that can be reported is called lymphovascular invasion. So what that tells us is, can we see tumors in the invading small blood vessels or lymphatics? So lymphatics are sort of a fluid transport system that goes through your skin and soft tissue, and it is how things drain into the lymph nodes. And so that is reported as present or absent in general. We like to see that there's no lymphovascular invasion. Perineural invasion lets us know if the tumor is going into or surrounding small nerves in the skin. Generally, we like to see that that is absent. And then sometimes we'll see, is this lesion, did it develop what we call de novo, meaning there was no pre-existing mole or nevus there, or is it developing within a nevus? There's maybe some prognostic significance to that, but we don't really put a whole lot of stock in that. I think that's more an area that's interesting for our future research, but not something that I really worry about when I talk to my patients. And then oftentimes you'll see the growth phase. So radial is the tumor is growing out, not deep, which is generally better. Vertical means we can see that the tumor looks like it's growing down deeper, which is not favorable. Okay, you'll probably see people look at, show you this a couple times in these presentations, but this all goes into melanoma staging. So stage 0 or 1 is when we have tumor that is confined to the skin, and you can see that it's in the epidermis or maybe very slightly in the dermis. Stage 2 is when we see the tumor that is going deeper into the dermis, or we see ulceration. Stage 3 means that that tumor has spread to the draining lymph nodes. And stage 4 is when we see spread beyond the draining lymph nodes. So the reason why we, in dermatology and your pathologist will focus on all these factors is what we're really trying to understand is, one, just looking at your tumor, are you stage 1 or stage 2, but also what is the likelihood that you have or will progress to stage 3 or stage 4 disease? And that's going to drive a lot of your treatment decisions and next stage steps in staging. Okay, so now we have our diagnosis, we know the tumor thickness, what happens next? So generally the next step is going to be excision of the tumor. So if you have a tumor that is just needs to be excised, where we don't need to do sentinel lymph node mapping, which others will talk about later, oftentimes that will just be done in your dermatologist's office. So if somebody comes to me and they have a 0.5 millimeter melanoma, it's not ulcerated, they're not a candidate for sentinel lymph node biopsy, I will often just do that excision in my office. If the patient has a tumor thicker than 0.8 millimeters, then we talk about and consider sentinel lymph node biopsy. So oftentimes that is a patient who I'm going to send to surgical oncology to have that discussion. Another a topic that comes up is something called Mohs surgery, which is where you can look at, it's where you have one person is surgeon and pathologist at the same time. They can remove the melanoma and check the margins as they go. The advantage of this can be sometimes if you have a melanoma where it's large but it's thin. We don't need a sentinel node biopsy, and we cannot really tell where it begins and where it ends clinically. There is a role for what we call Mohs surgery. This is the things that guide us in making decisions generally are what we call the NCCN guidelines. So it is in NCCN guidelines. I will say, however, most melanomas are not going to be treated by Mohs surgery. It's very specific scenarios. Sometimes patients hear Mohs and they think that sounds great. I just want to get Mohs surgery because it seems like the best form. It's really not always the best option, but I put it out there because you're going to hear about it, and there are times when it is where it is a good option. And then the other thing that our guidelines say is that sometimes patients are not good candidates for further surgery, or they have a very thin melanoma. They are much older. They're more likely to sort of die from natural causes than from this melanoma. So there is a drug called imiquimod, which is a topical medication that can stimulate an immune response to melanoma. And that is in the NCCN guidelines as well. So then what happens next, and we'll kind of focus on the earlier stage disease. So if you have stage 0 or melanoma in situ, we do send patients, or we bring them in, we do a full excision. We do recommend, or the NCCN guidelines recommend, an annual skin exam following that. But there's no recommendation for things like blood tests, sentinel node biopsy, scans. Really, this is just following up with your dermatologist. When patients have stage 1 or 2 disease, if we look at the guidelines, they suggest a skin exam with the dermatologist, preferably every 6 to 12 months for 5 years, and then annually after that. There's really also not routine imaging that's recommended. The imaging comes in generally when we have patients with more advanced disease, or more advanced than stage 2A disease, or if they are on therapies that you'll hear about later. Okay, so these are questions that come up for me too. One is, I've been diagnosed with melanoma. Should I tell my family to go see a dermatologist? So family history is a risk factor. So if you have a parent or sibling who has had melanoma, you are at an increased risk of developing melanoma. But that risk is sort of primarily associated with having a family member who was diagnosed before the age of about 50. So having a 90-year-old grandparent with melanoma does not concern me about somebody's risk. If they say my mother, had advanced melanoma at the age of 40, that makes me more concerned. Those are the patients who I want to make sure I'm seeing because of their family history. I think this is a good way to talk about, this is a good topic to bring up with your dermatologist, to not just say family history, but who was it and how old were they. And then only about 2% of melanomas are associated with known familial genetic melanoma predisposition syndrome. So what does that mean? The majority of people who get melanoma are not going to have, there are syndromes where we know you have a mutation in this gene that predisposes you to melanoma, but the vast majority of melanomas that we see are not in people who have familial syndromes. There's probably ones we haven't identified. If there is a strong family history, even if the patient has had genetic testing and it didn't reveal anything, I'm always in the back of my mind thinking there could be a gene we don't know about. I'm going to also let that family history guide me. The other thing that can also happen is that patients will say, oh my gosh, I had a melanoma, I'm going to tell all my friends to go see a dermatologist for a skin check, and is that warranted? So it turns out that we have a body called the United States Preventive Services Task Force that makes recommendations on screening, and they have actually said that we do not have sufficient evidence to recommend general population-based screening in somebody who's asymptomatic. So asymptomatic people who have not had skin cancer, do not have a changing lesion, we don't have to tell them to go get checked by a dermatologist. Of course, if they do have a suspicious lesion, always seek evaluation and care for that. So how about using sunscreen? We have one clinical trial that showed that sunscreen use is beneficial in preventing melanoma. So basically, this is what we call a randomized trial. Half the people were told, do whatever you normally do to protect your skin. The other half were told, here's some sunscreen, put it on your exposed skin. And then they just followed them over time. And the yellow group is the group that did not get sunscreen and the blue group did. And what you can see is the percentage of people with melanoma went up higher in the group without sunscreen. So there was a reduction in new melanomas in patients who did get sunscreen, and particularly that reduction was in patients who had invasive melanoma. So this is good evidence that melanoma can reduce the risk, sunscreen can reduce the risk of melanoma. There are also other studies or models that have looked at modeling prevention versus early detection. So prevention is sunscreen and avoiding, getting burned and tanned. Early detection is annual skin exams starting at the age of 50. No intervention is just show up if you have something you're worried about. And so in this model, compared with early detection, prevention was associated with fewer melanomas, fewer deaths, fewer other skin cancers, and a reduction in skin cancer-related healthcare costs. So in conclusion, your dermatologist is here to help you to understand your pathology report. No matter what your risk, your family history, if there's a lesion that's suspicious, please seek attention. Realize that family history is most important if that family member was younger than 50. And sunscreen is still your best friend. And the MRF patient website and caregiver symposiums like this are great resources to get really good, high-quality information. Thank you. Yes. So that's a great question. I tell patients it's about 30. So the studies would say it's 15, but the studies mean you put on enough, which none of us do. You reapplied it enough, which none of us do. So 30 gives you a little extra buffer that you're probably in reality more like 15. And if people are going to be at the beach and outside all day and exercising, I'll tell them go to 50 or higher. Yes.
She didn't pay me to do this.
Uh-huh.
Another question, vitamin B3, is that correct?
So nicotinamide, yes. So nicotinamide has been shown to reduce the risk of variable data, but nicotinamide is a supplement, 500 milligrams you can take twice a day. It has been shown to reduce the risk of squamous cell carcinoma of the skin, although we don't have, in the pretty large studies, we don't really see a significant reduction in melanoma risk. But nobody wants a squamous cell carcinoma either. They're much more common than melanoma. So yes, that is a good prevention. Thank you. Any other questions?
Question for you.
Yes.
Melanoma with an unknown primary.
Yeah.
I go to the world's second best. You're probably the best dermatologist. I go to the world's, seen her for 15 years. She actually went to North Carolina.
We know she's good then.
They cannot find any melanoma on my skin. What percentage of patients would you say are in my situation?
So it's a low percentage, but it's not something we never see. I'm going to put it the 5% range. So why does that happen? We don't really know. So in general, to be honest, I don't think it's that I think your dermatologist is fantastic, and I don't think that he or she missed your melanoma. Yeah, no. And so I think what can happen is that sometimes melanomas will actually regress. They will go away completely on the skin, but we think that might be after they've already shed some of the tumor into the lymphatics or bloodstream, and so we pick it up later. There's probably also, lesions that occurred that were teeny tiny and regressed. We don't even know that all of these originated in the skin. It's a really tough problem. Interestingly, there's some data that patients with melanoma of unknown primary actually have a better prognosis than those with a known primary, so I think there's still so much we don't know. Anybody else? Yes.
Genetic screening. If you have, I'm a stage 4 survivor, so I'm naturally concerned about my children's risk coming forward. So can you just maybe talk a little bit about screening? I know you said under 50.
So there's we tend to think about it, like one of the things I think about is like sort of rules of 3. So if a patient has had 3 or more primary melanomas particularly with the first one being that are invasive, not the in situs, because they're very common. But if somebody has had 3 or more invasive melanomas, particularly with one starting before age of 50, those are patients who we'll talk about, sending for screening. 3 or more first-degree relatives, so parents, siblings who have had melanoma, makes me think about genetics. And then there's also a cancer predisposition syndrome that puts you at risk of melanoma and pancreatic cancer. If I see patients, in that immediate family where there is both melanoma and pancreatic cancer, those are also patients who I tend to talk to. And again, I'm not saying get genetic screening, I'm saying consider and talk to the genetic counselors. There's a myriad of issues with genetic screening that I feel like the people who have devoted their career to genetic screening are going to be able to give you a better discussion than I am. So I usually send you for a conversation. I don't ever order the screening myself. Yes.
Yes, I have a question about, can you talk to us a little bit about patients who are redheaded, fair skin versus my husband here who's from Italy and has that great skin. When he goes out in the sun, he just automatically tans and I burn like a tomato. Could you tell us the risk for me versus him and the different levels of how that works?
Yes, so being a redhead, so having fair skin, so we call like phototype 1 or 2, which is you basically burn and you don't tan, is a risk factor for developing melanoma. Having red hair, there's a gene associated with that also puts you at increased risk. So, my patients who are redheads and fair-skinned like you, I do counsel them that they need to be more careful with the sun. So your husband can probably go out and be outside for a little bit, get a minimal tan, and in that same time you'll get a sunburn and you're probably never going to tan. It is associated with increased risk. All you can do is prevention. So it's not never go outside. It's wearing things like wearing a hat. Maybe you bump up to the SPF 50 sunscreen. Yes, and wear, sun protective clothing, but that is definitely a risk factor, and we see that across lots of epidemiologic studies too. Yeah. All right, thank you all so much.
Diane Bensley here. She is. Diane Bensley is our social worker extraordinaire. She is incredibly busy, but always gracious and sees our patients in a drop of a hat. And she's going to talk about financial toxicity in cancer care, which is ever more present and daunting. Thank you, Diane.
Do I just hit the...
Mouse, if you want to, you can forward, back, and then that's your pointer. If you wanted to use that one. Okay.
All right. Hi, everybody. As Paula said, I'm Diane Bensley. I'm one of the 4 oncology outpatient social workers here in the Cancer Hospital. And I'm here to talk to you today about potential for financial toxicity in cancer care. And what is financial toxicity? This is just what some patients can encounter while they're undergoing treatments. It refers to financial stress, burden, or challenges that patients may encounter. And some of the financial challenges that patients can encounter during treatments are the cost of treatment and out-of-pocket expenses. Cancer treatments, as we know, can be very expensive. And even with good insurance, sometimes there's still copays and deductibles that need to be met. Loss of income from reduced wages. Many people can't continue to work during their treatments, so their income could either be reduced or depleted altogether. And transportation and lodging. How will patients get to their appointments if they don't have money for gas, if they don't have a car, if they don't have someone that can bring them? We also know that financial toxicity is correlated with lower health outcomes. This can happen easily if patients, again, can't afford transportation to get to a clinic or hospital, and they delay getting a diagnosis or they delay getting their treatment. And patients may not want expensive treatments if they don't have insurance, if they don't have money to pay their bills during treatment. Other patients may need to decide between expensive medications that they get outpatient or buying food. And financial toxicity can also negatively affect someone's mental and emotional health, and this again can delay treatments, or maybe patients can't even finish their treatment plans. So let's take a little bit of a closer look at each of the categories that I mentioned. The first one is the cost of medical treatment. This can be very overwhelming and stressful for both those that have insurance and that maybe don't have insurance or are underinsured. Some of our patients, they do not have any type of insurance at all. They don't have employer-based insurance. They don't have Medicaid. They don't have Medicare. Would they qualify for Medicaid? Perhaps, and as social workers, we can meet with them and try to determine if they would qualify for Medicaid. If they do, we explain to them how to go to their local Department of Social Services and apply for that. Maybe they would qualify for an ACA or a marketplace plan. Some people call them Obamacare plans. Again, we can point patients in the right directions to sign up for one of those. We also have UNC Financial Assistance, and we call it PAP, which is our pharmacy assistance program. The patients can get these applications. It is dependent on their income and their assets, whether they will qualify. As social workers, we tend to get involved with patients that are really finding these applications challenging, and we can, go through the applications with them and tell them in detail what documents they have to bring back in. There's a lot of documents to go with those. UNC also has a wonderful program for patients whose job may have ended and their employer offers them COBRA. And what COBRA is you're just keeping your employer's insurance plan, but a patient would have to pay their portion of the premium and the employer's portion of the premium. So this can be really expensive. So if a patient does get COBRA, UNC Cobra Care UNC has a program called UNC Cobra Care, where UNC will make those premium payments for the patients. A patient would have to be in active treatment, meaning they're receiving IV chemotherapy or radiation treatments. If they are, we can help them to apply. If they qualify, UNC will make those premium payments up to 18 months if a patient's in treatment that long. So what I like to tell patients is if you hear anything about COBRA, just call one of the social workers. We'll get you the application and we'll help you fill that out. In the past year, patients have also been dealing with some insurance company issues and challenges. For example, there were a few insurances that went out of network with UNC this year. A couple of them were the Medicare Advantage plans, Humana, Cigna, and WellCare. So UNC partnered with a company called Chapter. It's like Chapter in a book, and they offered free personalized Medicare guidance for our patients. And that's their phone number. The next category is loss of income from reduced wages. Some employers do have short-term and long-term disability benefits. If your employer has those, you can reach out to HR and they will help you to get started with that paperwork. There's also Social Security disability insurance. That is kind of dependent on the stage of the cancer. For melanoma, it's typically a stage 4 that would get you Social Security disability. As social workers, we cannot apply for you, but we can tell you how to do it. You can either go online at ssa.gov or call your local Social Security office. There are a few cancer grant programs out there that can help patients with household bills while they're getting treatment. Unfortunately, there's not a lot out there right now, but as social workers, we can connect patients with the ones that we do have. One of the main ones that we use is our UNC Cancer Patient Assistance Fund, or CPAF. Excuse me, they can pay up to $250 a month, or a year. It's only $250 a year for like a utility bill or another household bill. This is dependent on a patient's income and if they're getting treatment at least monthly. We also encourage our patients to call 211. This used to be the United Way, and if you call 211 and tell them what county you live in North Carolina, they can tell you of any community programs that might be in your county. For example, if there is a Salvation Army that might have some funds, or sometimes area churches have funds that can help with utility bills. We also encourage patients to call their local Department of Social Security if they have a disconnect electric bill. If you have a disconnect electric bill, you call DSS in your county, and if they have any funds, they'll help with that. So transportation and lodging, as I've mentioned, transportation can be a really expensive barrier to our patients, especially those that are coming often for treatment or traveling afar, even sometimes those that are traveling close by. Medicaid and a couple of the Medicare Advantage plans do have transportation benefits, and we can help patients access those benefits. Our Cancer Patient Assistance Fund has a gas card program for those that qualify. Again, it's dependent on income and if you're coming at least monthly for treatments. We also have a few parking passes. This year, I think it's up to 60 hours a year for parking passes. You do have to qualify for the gas cards first. We also try to work with patients to see, do they have any family, friends, neighbors, church members that can help bring them to their appointments. And sometimes if they can, the gas cards can help for those folks. So lodging is also sometimes needed to accommodate those with consecutive outpatient appointments. Our Cancer Patient Assistance Fund can help pay for lodging at the SECU Family House if there are consecutive days of appointments and patients qualify based on their income. The radiation oncology has a lodging program where if a patient has consecutive days of radiation treatment, radiation oncology would actually pay most of the costs for a patient to stay at the family house during that period, Monday through Thursdays. So I think the most important thing to remember is if a patient or anybody is experiencing financial challenges or stress, they should reach out to Paula or one of their physicians who can then make a social work referral to see one of us. We always are willing to talk to patients, see patients, to see what resources maybe that they'll qualify for, because we want everybody to be able to get their treatments, complete their treatments, and get the best care possible. This year, there's also a new program. We call it OPNs. It's Oncology Patient Navigators, and they can assist with identifying any potential barriers to care. They're going to be making outreach phone calls to patients before treatment, during treatment, and to see what barriers they have. And actually, they're just another layer of support for our patients. And I think Kelly is going to speak to that in a little bit. So for the rest of us, how can we help with financial toxicity? Well, Paula and I were talking one day, and there's just such an increased need for donations to be made to these cancer funds. There's just not a lot of help out there. So Paula was thinking, hey, maybe instead of another, birthday present or a holiday gift, that your family could donate to a cancer community foundation or to our Cancer Patient Assistance Fund here at the hospital. Because really, do we need another ugly Christmas sweater or tie? Any questions?
Is there a baseline when you're talking about a lot of this is going to be income-based?
Yes, yep. Our Cancer Patient Assistance Fund is based on a patient's income. It's based on 250% of the federal poverty level. I don't have my scale with me here, but yes. Mm-hmm. Thank you.
We're gonna have, Debbie's gonna, okay, yeah. Do you know how to hook up?
I was wondering, yeah, I can, is it okay if
Yeah,
I just?
yeah.
Test, test. I'm just making a quick announcement before our next speaker. You may have received a pre-test survey when you checked in. So if you could grab those out, Debbie is holding them up. Here at the Melanoma Research Foundation, we're always creating new education materials. And as you saw in your folders, we have lots of materials available for you for free, and you can order them on our website, which Debbie will share later. But we are creating a new material based on subcutaneous administration of immunotherapy. So if you could fill out the pre-test, it's not a test, you're not graded, it's just a survey. So if you could fill that out now before Dr. Hanks speaks, then at the end of his presentation, we're going to give you a post survey to see what you know, and then that information will be used for us so that we can create new education materials.
If anyone didn't get one or needs a pen,
Oh, you have one back there, Debbie.
I'm sorry?
And I'll walk around and grab the pre-tests. Again, you're not graded.
And just really quickly, I wanted to introduce Brent Hanks while we're getting set up here. He is one of our wonderful medical oncologists, one of our newer medical oncologists to UNC, and has been a wonderful addition to taking care of all our patients. So he's going to talk a little bit about his role here.
Okay. Yeah. Hope everybody can hear me okay. Okay, great. Okay, I've been asked to talk to you guys about medical management of melanoma, so I'm going to go over a couple of different topics associated with that today. Very brief outline. I wanted to give you a historical perspective on managing melanoma, managing advanced melanoma, and kind of where we've come from and where we are now. Our current treatment options, largely immunotherapy-based options versus what we refer to as targeted therapy, or biologically targeted therapeutic options. And then also some of the challenges that remain in the field and what we really need to do in order to continue to improve outcomes for our patients with melanoma. So this slide is really meant to emphasize a very long period of drought, therapeutic drought for over almost 40 years, where we had 2 agents that were FDA approved for managing advanced melanoma. Obviously not good. This included the dacarbazine chemotherapeutic as well as IL-2, which is a form of immunotherapy that was really only available at select tertiary care medical centers across the U.S. And to give you further perspective on this, in a 2,100 patient meta-analysis involving 70 different phase 2 clinical trials between 1970 and 2000, there was no improvement in progression-free survival when these studies were broken down by decade. So indeed, 1-year overall survival prior to 2010 was approximately 25%. So fortunately, we have come a long way. We have benefited from 2 key therapeutic innovations that have really revolutionized the management of advanced melanoma, as well as other advanced skin cancers. Where over the last 15 years, there have been a series of both immunotherapy options, shown here in red, as well as targeted therapy options, shown in blue, that have been FDA approved for the management of melanoma. These therapeutic innovations have now improved 1-year overall survival to approximately 70 to 80%. So clearly, these agents have made a significant impact on the management of patients with advanced melanoma. So I wanted to go over just very basic background. What exactly is immunotherapy anyway? And how the anti-PD-1 immunotherapeutics work. What I'm really referring to here, of course, is largely nivolumab or Opdivo, pembrolizumab, Yervoy, pembrolizumab or Keytruda. So T cells initially arrive in tumors ready to fight and destroy melanoma cells. Very aggressive. But over time, these T cells will become exhausted. And the delivery of the anti-PD-1 immunotherapeutic serves to really reinvigorate these CD8 T cells, enabling them to eliminate more of the tumor. So that's essentially how they work. They're essentially promoting their activity by reducing their level of exhaustion, promoting their ability to eliminate those melanoma cells. And then when we talk about the targeted therapies, of course, we're really talking about mostly BRAF-targeted and MEK-targeted therapeutics. You can think of BRAF as an on switch that tells melanoma cells to divide and proliferate. Under normal conditions, certain growth factors may promote activation of this BRAF switch. And however, when BRAF is mutated, the switch is broken, resulting in a constitutive on signal that drives uncontrolled cellular proliferation. And unfortunately, this drives melanoma progression. The introduction of a BRAF inhibitor shuts this signal down and suppresses further cell proliferation and tumor growth. So that's how these agents effectively work. But the targeted agents are really restricted largely to melanomas that harbor BRAF mutations. So these mutations are found in approximately 50% of cutaneous melanomas. The BRAF inhibitors block mutated BRAF signaling, while the MEK inhibitors block MEK signaling in the same pathway that tells these cells to divide and proliferate. And when you combine these agents, you get greater benefit, longer lasting response. So these inhibitor regimens can shrink melanomas in a very high percentage of cases. However, the issue is that the resistance to these inhibitors often develops over time. When we compare targeted therapies with checkpoint inhibitor immunotherapeutics, you can see that the targeted therapies are provided by oral administration. Immunotherapies are intravenous. While targeted therapies can induce rapid responses, the responses to immunotherapies are generally more delayed. The objective responses to BRAF-MEK combination inhibitor therapy is approximately 65%, while the objective responses to combination immunotherapy is approximately 55%, so pretty close. However, the durability of response to the BRAF-MEK inhibitor combinations is generally more limited, while longstanding responses to immunotherapies can be observed. And this is reflected in the differences between targeted therapies and immunotherapies in terms of their progression-free survival. I think you can see on the left, targeted therapies outcomes, progression-free survival at 5 years is roughly 19% for BRAF-MEK inhibitor combination therapy, while 5-year progression-free survival for combination immunotherapy is approximately 37%. So improved outcomes in general. So now that we have immunotherapy and targeted therapy options, one question that really came up in the field that was, of course, very critical to address is which treatment should be given first. And the question was recently answered by a clinical trial called the DREAMseq clinical trial, which evaluated overall survival of treatment-naive stage 4 melanoma patients that either start with immunotherapy first versus targeted therapy and then switch to the alternative treatment strategy at the time of disease progression. And I think it's notable that at the time this study was done, approximately 50% of all BRAF V600 mutant melanoma patients that were receiving treatment in the US were receiving first-line BRAF-MEK inhibitor therapy. As you can see in the overall survival curve, those patients that received immunotherapy first did much better. And so since this study has been published, this is now considered standard of care to initiate patients with immunotherapy first right out of the gate. So I think it's also clear that in this particular study, there was evidence that responses to immunotherapy after progression on targeted therapy was also much less. And this is something that those of us that were taking care of melanoma patients at the time could attest to. So none of this is really a surprise. It was very clear that when a patient progressed through targeted therapy, that subsequent responses to immunotherapy were significantly diminished. So the take home here is that we start our patients out with immunotherapy first, but there are other considerations. We do consider BRAF-MEK inhibitor therapy when a rapid response is needed, and then we also consider transitioning those patients to immunotherapy after a couple of months of treatment on that agent. It's also notable that combination ipi-nivo ipilimumab and nivolumab immunotherapy is really superior to treating patients with CNS involvement. So there's other things to consider, but by and large, we'd initiate patients on immunotherapy first. So it's also notable that we now have 2 subcutaneous injection immunotherapies that are FDA approved for patients with melanoma. So there's a nivolumab form that's delivered sub-Q. This is delivered under the skin by syringe, as well as a pembrolizumab form that's delivered sub-Q by syringe. This is generally delivered to the thigh or the abdomen in the clinic by a trained healthcare provider, and drug delivery is typically faster than what we see with intravenous delivery. However, I think it is fair that we have to consider that the agent does have to equilibrate to room temperature for 30 minutes prior to administration, so there's a little added time there. But it does offer alternatives for patients with venous access challenges. So overall, these therapeutic innovations are brought us from an era where only 10% of patients were actually responding to our treatments to now where approximately 50% are responding. So to look at this in a different way in terms of long-term overall survival, we have approximately 50% of our patients that demonstrate benefit to combination immunotherapy regimens. So one can look at these transformative differences as a glass half full or glass half empty perspective. While significant advances have certainly been made, it remains true that approximately 1 out of every 2 patients that we see are still not benefiting from our treatment. So how do we improve on that? Well, we have improved overall survival clearly with the immunotherapeutic options that we now have available. Questions remain about how to continue to shift the survival curve up. And this is essentially where we are now. Challenges and significant challenges remain. To continue to improve these outcomes, we have to address these challenges. And I would submit to you there are primarily 3. One is overcoming immunotherapy resistance, and that's going to require a better understanding of immunotherapy resistance and how tumors evade the immune system and promote resistance to these agents. This ultimately will lead to novel and improved therapeutic options. 2, developing an improved understanding of the mechanisms of immunotherapy-associated side effects. So devising strategies for better management of these immune-related adverse events in a way that does not interfere with the effectiveness of the therapy. And then finally, how to integrate all of this information and all of this knowledge and tailor it to the individual patient. So these are significant challenges. In addition to primary resistance to immunotherapeutics, it should also be recognized that there's secondary resistance that also occurs in patients with melanoma. Indeed, 20% of patients that have demonstrated a complete response to immunotherapy exhibit disease progression within 5 years. 55 to 60% of patients that have had a partial response to immunotherapy will develop disease progression within 5 years. In real-world melanoma patients that have previously demonstrated a response to immunotherapy, 46% will develop disease progression in 1 year. Now, keep in mind, this also depends on the level of response that we see in patients. So there are nuances here. But the question is raised, how do we overcome these resistance patterns in immunotherapies? And it is generally believed that combination therapies will be necessary. And there are many, however, there are many potential combinations. There's a schematic on the right showing a list, a variety of different potential targets that have been put forward. How do we test each of these combinations effectively? And it's also true that it's likely that different combinations are going to be more effective in different patients. So it is now very clear that predictive biomarkers will be needed to guide this process and to tailor the appropriate combination regimen to the appropriate patient. And as at this point in time today, we have none. There are several potential immune-related adverse events or side effects that can develop. Many of you know this. Some of these more common side effects include dermatitis, inflammation of the bowel or colitis, thyroiditis, inflammation of the thyroid, inflammation of the pituitary, otherwise known as apophysitis, inflammation of the liver, hepatitis. And so these particular side effects, they limit select patient populations, those patients that have a history of autoimmune diseases, those patients that have an organ transplant. are all limited in their ability to receive these agents because of these side effects. It is interesting to note that immune-related toxicities correlate with response as well as better overall survival in many studies for those melanoma patients that have been managed with checkpoint inhibitor therapy. Our understanding, however, of these toxicities remain very poor. We have very little understanding of exactly why a particular side effect develops, and we have absolutely no way to predict which side effect is going to develop in who. In addition to that, our current treatments are very limited, as they can impair the effectiveness of immunotherapy toxicity. So I think it's clear that very much significant research is needed to overcome these barriers. It is also becoming clear that many characteristics of the tumor, as well as the patient, as well as our environment, will ultimately influence the optimal treatment for the individual patient. So as of now, there are intense efforts underway to identify biomarkers associated with increased efficacy as well as resistance. This includes tumor-based markers, patient-based markers, as well as even environmental influences that you'll hear about later. And by integrating these, the idea is to develop a better signature system to identify which patients are more likely to respond to what. Unfortunately, at this time, I can honestly tell you that we're very far behind in this endeavor. Using an improved understanding of both treatment resistance and immune-related adverse events, I think if we look at those patients that are not currently benefiting from our treatment options, it is possible to tailor these therapeutics in a regimen that's meant for the individual patient that's most likely to generate a therapeutic response while also minimizing side effects. And it's very possible this will ultimately serve to shift the survival curves north in melanoma as well as in other cancer types. So our past, only 10% of patients responding to different therapeutic options are present. Approximately 50% of our current melanoma patients are responding primarily to immunotherapies as well as targeted therapy agents. And then I would submit to you that with much more research, we'll be able to continue to shift this curve north using novel therapeutic combinations. So understanding mechanisms of treatment resistance and side effects can lead to rational therapy combinations as well as sequencing regimens as well as predictive biomarkers that are necessary to guide therapy selection for specific patients, broadening those patients that are able to respond to these therapies, and improving clinical outcomes overall for our patients. Thank you.
Hello.
Hello.
I have a question about one of the slides where it was the three slides, the three common things that were challenging for response.
Okay.
If you can go back to that slide.
Sure.
One was skin rash, overcoming the resistance of melanoma. Did he cause this?
Are you referring to the different side effects?
Yes.
Okay.
The different side effects.
Yeah.
The rashes, the colitis,
Right.
and all of that.
Right.
Who's doing the research and development that would help be proactive in that before you get the immunotherapy? Or is there such research and development being done?
There is.
Or is it just by individual patient? We just wait, give it to you, and then see what happens.
So
But since they're the common three, are we doing anything to help those common three things? Does that make sense?
Yes. I mean, I think in short, the answer is yes. There are studies that are going on looking at, a variety of different approaches for looking at markers associated with the development of some of these side effects. There's different prospective studies that are ongoing now in a variety of different institutions across the country. So I think that this work is actually quite challenging because there's many different side effects. They all behave in a different way, and they're likely to be related. Their underlying mechanism of the development of the side effects is likely to be different. So it's a heterogeneity in terms of the side effects. It's a heterogeneity in terms of the patients. In addition, we have challenges associated with these studies because we have to rely on clinical documents in a lot of cases, and sometimes that can be limiting. So, in short, this is ongoing. I think that it has not been a primary a priority by a lot of parties. Dare I say, industry. It's not necessarily been a huge priority. And so there's been less dollars really dedicated to that type of work in the past. Yeah.
Read up on Dr. Hanks. He is actually one of the nation's experts on why people get side effects and why they don't. We're sitting here with a genius, really. What can we do to assist you in your further studies as patients? I mean, is there anything more that we can do to, join a clinic or what you do that we could help your study and advance your research?
Great question.
I think, honestly, at this point in time, you guys may know that there's a significant problem in terms of federal government funding. So, at least in my personal career of being involved in this work for 16, 17 years, this is definitely the most difficult period that I've ever encountered. So, honestly, I think if there's mechanisms or there's ways to get involved in raising research dollars for the institution, I think that's something that would be very useful. These kind of dollars can go for helping us pay for trainees to go to different conferences, to pay for the rising cost of even manuscript publications. I think in addition to the lack of funding, we're also faced with extreme increases in costs of different materials and reagents in our work. So we're getting it from both ends, basically. So it has been very difficult from a financial perspective.
I had a question. Is this type of therapy the same as the one that's given through the IV? Is this the same thing? Or is this more like personal injections, or is there a difference?
So you're asking about the immunotherapy drugs?
Yes.
Yes. So historically they've been given mostly intravenously or exclusively intravenously, but there are two options that are available now that you can deliver sub-Q under certain circumstances. And these are delivered in the clinic by another healthcare provider, but that is an option. Yeah. And studies have shown that their effectiveness as well as potential side effects are similar. Yeah.
I'm probably the most unknowledgeable person about it. I've been on chemo now since 2012.
Okay.
What's the difference between immunotherapy? Because I don't know.
Okay. So chemotherapy essentially attacks the cancer directly, right?
Yeah, I take 4 capsules and 4 pills a day, every day.
Okay.
Hadn't missed one in all since 2012.
So these.
I feel like at 85 I'll
Yeah.
be in July.
I see.
I'm doing very well.
Uh-huh.
I don't know if I have any of those other things. Do they show up in my PET scan? All these things can be affected.
Not necessarily. I think
have
if
any
you
of those.
if you would know if you had it.
Well, I'm almost 85, so I get tired. But it's like you got
I do
that's
too.
on one of the
Yeah.
charts. Tired. Well, I stay
Yeah.
tired, but I'm a busy person and a lot of
Right.
things I'm involved in. But I'm keeping on going.
Yeah. Good.
I'm not letting it stop me.
Good.
I just don't understand. How would I find out if I have any of that block?
Well, I would say that if you have nothing that's concerning you, I probably wouldn't raise the question. Now, these are side effects related to immunotherapies. If you're not on an immunotherapy,
That's what I'm
then
saying. Chemotherapy is not the same. as
not the same. That's right.
And that's what I was
And
trying
the
to say.
side effects are very different.
How would
That's
I
right.
know if I have it from the chemotherapy?
Well, you wouldn't have, it'd be very unlikely for you to have these
I mean, it doesn't
issues.
affect any of my organs
Right.
in the chemo that I'm swallowing.
Yeah, so you're not going to have these side effects
That's what
with.
I said, I'm
with-
not knowledgeable.
Right, okay, with that chemotherapy drug.
Thank you.
Hey, sounds like you're speaking to my wife here. She started, had something, had part of her ear removed, and then went to immunotherapy, now we're at the BRAF inhibitor stage of things. So from what it sounds like to me, it sounds like that's just a secondary step down after immunotherapy doesn't work, that it goes to BRAF inhibitors, and then it becomes a maintenance thing. But did I hear you say that there's a possibility that you could transfer back to an immunotherapy after, if it loses effectiveness, or is immunotherapy not going to work anymore after you've gone down the step down to the BRAF inhibitor?
I mean, it's really going to depend on the specifics of the circumstance, honestly. I think that those therapies the BRAF MEK inhibitor therapies are very useful and can be often used in some cases, in some patients, over a more prolonged period of time. But they can also be used to bridge patients to other types of therapies. So if someone has not responded well to our current standard of care immunotherapies, there are other immunotherapies available that could be considered depending on the circumstances.
She's responding really well to the BRAF inhibitors, but worse really bad under the immunotherapy.
Sorry. So you're doing research here regarding these types of things, is that correct?
Yes.
Are you guys incorporating things with integrative medicine into that?
Define integrative medicine.
Well, it's pretty broad, but primarily diet is my newest interest.
My group does not address issues such as that, but there are certainly others that are. We know for that for sure. I mean, and so that work is going on. Yes.
I like your question a lot about incorporating that. Because you are what you eat, and we'll probably get into that later with Dr. Moscos probably, but
Right.
Back to the research and development and the three things, and you said you needed our help to get funding. Tell us, give us A, B, and C, what can we do just as survivors to help you get that funding? Do we need to call our state senators in our region? What do we need to do?
I would encourage you to probably communicate with the UNC Development Office and Lineberger Cancer Center Development Office, and they would have a lot more sophisticated information for you than I would.
Okay, so you're saying the UNC Development Office?
Well, the Lineberger Cancer Center Development Office, that's my initial response to that. I think that they're certainly going to have, they may have different terms for those offices, but those are the individuals that really help to coordinate philanthropic endeavors and to help out research at the institution.
I've recently found a lot online, a lot of melanoma research and development, the Melanoma Alliance, a lot of other organizations that's raising money for melanoma research and development all across the country. One, Teddy Mellencamp, John Mellencamp, a lot of people are too young to remember John Mellencamp, but I'm not. But his daughter's going through that, and she's being treated in California. I think it's Cedars-Sinai. But they are doing fundraisers that I accidentally became involved in, but that's what it's going towards.
I see.
So I just wondered here locally, since you're here and you're the champion here, what can we do to help you? I don't want to go out and walk a 10K. I will do that, but that's
Right.
not going to raise much money for you.
Yeah.
If you look at UNC Health Foundation, they have funds specifically to melanoma research happening at UNC.
Yeah.
So if you go to their website, they have it.
Okay.
Yeah. And there's different foundations as well.
Thank you, thank you. Dr. Hanks, question for you on whether or not you think the next frontier of melanoma treatment is going to come out of industry, clinical research, or investigator-initiated studies?
You mean, what's the original source of that?
Yeah, what's next?
I don't know who's in the audience right now. Honestly, it's going to be an academic investigator that initiated, that's going to kick it off.
Okay.
I think that's the creativity is definitely a lot higher.
Yeah.
Yeah.
Thank you so much.
You're welcome. You're welcome. Let me get this fixed for you. Okay. Here he is. The good news is that you have an easy to work with system here. There you go.
Thank you. Thanks so much. Yeah. Okay, we're trying to keep on time. We're very excited once again to have the Melanoma Research Foundation help us with this program. We couldn't do it without them. And so Debbie Churgai from the foundation is just going to talk a little bit about the foundation and what they do and how they help us.
Thank you. Hello, everyone. My name is Debbie Churgai. I'm the Senior Education Program Manager at the Melanoma Research Foundation. And whoever asked the question about, what they can do to help or wanting to know more about research and advocacy, I can tell you a little bit more in this presentation. If you guys don't know, we partner together with UNC Lineberger Comprehensive Cancer Center to put on events like this for you guys. I want to first thank our sponsors, Bristol Myers Squibb, Pfizer, Merck, Immunocore, Castle, Iovance, Regeneron, Delcath, and Mantix. We cannot do events like this without their support. These are all amazing companies that are helping to support patient events like these. We have a few industry reps here. If you are an industry rep, can you just put your hand up? If you guys have time to talk to them, please say hello. Thank them for being here. It really means so much to have their support here. I also want to say thank you to UNC. We've been having this event together for how long? How many years do you know? At least 14 years we've been partnering together. So thank you to Paula, Donna, Patricia, Melody, and everyone here at the center. We have a great partnership with them and hope to continue it. First, I just want to give just a few overviews about melanoma, although you guys probably already know this. In 2025, 212,000 people are living and expected to be diagnosed with melanoma. Nearly 93% of melanoma are thought to be caused by exposure to UV light and sunlight. Melanoma is not just a skin cancer. It can develop anywhere on the body's eyes, nails, feet, mouth. And the 5-year survival rate for stage 1 to 2 localized melanoma is 97.6%. I'm just going to give you a quick overview of the Melanoma Research Foundation. I'll probably go a little faster than normal since we're a little bit behind time. The MRF, as we are known, is the largest independent organization devoted to melanoma, committed to the support of medical research to develop effective treatments and eventually a cure for melanoma. We educate patients, providers on prevention, diagnosis, and treatment of cutaneous melanoma. Oh, and sorry, rare subtypes as well. This is our founder, Diana Ashby, who was diagnosed and founded MRF in 1996. After a 3-year battle, she found that there were no options for new therapies in clinical trials. It's a picture of her and her husband, Captain Jeff Ashby. Diana's legacy lives on through the MRF and all the incredible work that we do. The MRF consists of 3 pillars: research, education, and advocacy. As I said, I'm part of the education department, and this event right here is what we do in our education department, as well as you'll see in your folders, there's a ton of free educational materials. That's also what we do, but I'll talk a little bit more about that. The MRF hosts several events all year, including over 19 5Ks in different cities and states, 2 signature galas. We bring patients and caregivers to DC for our annual Advocacy Day to talk with congressional leaders about what is needed, why research is needed, why funding for research is needed. And we host 6 patient symposia like this all over the country, and then we host another one specifically for a rare type. Research is truly at the heart of our mission, supporting scientists whose discoveries lead to better treatments, improved outcomes, and new hope for melanoma. This slide highlights some of the groundbreaking research that MRF has funded in the past and continues to support today. We have awarded 34 grants in 2025 alone and have funded over $28 million in research overall. This right here, since the MRF has provided over $700,000 in funding to UNC through 7 grants that supports melanoma research. These grants have produced exciting results for the melanoma research community, including 11 publications and 9 scientific collaborations. You may recognize some of the awardees, including Dr. Hanks. So also, an interesting fact is, if you guys didn't know this, funding melanoma research, you're also helping to advance all cancer research. Melanoma research breakthroughs have led to approvals in both targeted therapies for BRAF mutations and immunotherapy treatments for many cancers. As you can see, all the different cancers that started out with melanoma has helped all those other cancers as well. Another facet of our research is our Breakthrough Consortium, which accelerates melanoma translational research through multi-institutional collaboration. And you can see all of the research centers that we partner with, including University of North Carolina. As I mentioned before, we have a variety of educational opportunities directed at patients, but we also educate caregivers, family members, providers. Our educational offerings include educational materials, webinars, animated patient videos, symposia, and we talk about rare subtypes as well. We have created over 30 pieces of educational literature. What you have in your folders is just a handful of things that we have, as I mentioned, 30 that are all free to order for clinics, schools, community events. Topics include cutaneous, ocular, mucosal, pediatric, youth prevention, clinical trials. We have so many amazing things online. Please, if you haven't looked at our website, check out our website and check out all the free educational materials that we have available. If you're going to an event, if you want to help spread education, we can help you do that. We also send these physician offices, dermatology offices all over the country. So if you want to give some to your local offices, you are welcome to have them contact us and order it, or you can order it for them. Order form is on the educational literature page. We make it really, really easy for you, and as I mentioned, totally free. We host monthly Ask the Expert webinars. We also have 6 animated patient videos and a few more currently in production. These videos are all less than 10 minutes long, and they pack in a lot of information with great visuals. And if you're looking for more educational content, please check out our YouTube page. We have over 100 on-demand videos that can be found that include past symposia. This symposia will be available on our YouTube channel probably in about 2 weeks. We have all our past Ask the Expert webinars, patient testimonials, so much to offer. We also have an amazing community and patient forum. This is dates back quite a while, so there's a lot of amazing topics and conversations, including new therapies, how to handle grief. If you're looking for someone to talk to about something, you don't have anyone, please check out our patient forum. You can do a search for topics, or you can start a new topic and a new conversation. I also wanted to introduce, you may have seen this postcard. It's our new Sun Safety e-learning educational program for children in kindergarten through 5th grade. It's to encourage healthy habits that prevent melanoma, skin cancer, and sun-related skin damage. Also, this program is completely free. We are right now talking to all different schools across the country, youth programs, trying to get this into different places across the country to help spread education for our youth. Please check it out on our website. Again, if you want to talk to your local schools, we have a PowerPoint presentation you can share with them. We have these postcards that you can order for free, or you can just come talk to us anytime. As I mentioned before, every year we bring patients and caregivers to the Hill to meet with congressional leaders. We also work with legislators and policymakers to help increase funding for cancer and specifically melanoma research. If you would like to attend one of our advocacy days, let us know. We just had one March 1st to the 3rd, so we just had it. But if you're interested in attending next year, please contact me and we'll get you on that list. We have several prevention and awareness campaigns. You may have heard of them sometime, or and didn't know they were connected to us. I know you mentioned Telly Mellencamp. She was our Get Naked spokesperson last year. And we also have I Get Dilated campaign, our ocular melanoma campaign, Out of the Shadows for mucosal, and of course our Spot the Dog campaign for pediatric melanoma awareness. We also have several programs we support, such as a Dermatology Alliance Council, Breakthrough Consortium, and a Mucosal Melanoma Initiative. There are many opportunities to support the work of the MRF through a variety of programs, events, research funding. If you're interested, reach out to education@melanoma.org. A lot of you might have my email, so please feel free. You can just email me directly, and we can talk about different ways you can help support our research and get involved in the community. Lastly, I just want to say, if you want to learn more about the MRF, all the events, all the educational materials, everything that I've mentioned today, advocacy, our research, just follow us on social media. We're on all the big channels, and we spread a lot of awareness through social media. Oh, the other thing I want to mention was we forgot to put this in your folder. And I'm sorry to ask you again to fill something out, but at the end of today, we have a post-event survey which talks about all the presentations you heard today, all the speakers. It's very short, I promise. We would love to get your feedback because we do give that to UNC afterwards. We let them know, here's what everyone thought of this speaker, here's what everyone thought of the symposium. This is why we continue to have this here every year, because we get such great feedback every year. So it really does mean a lot to us, and it means a lot to them. If you could fill out this survey, you can do it as you go along. Once you hear a speaker, you could do it at the end. We do have it online. If you'd rather do it through your phone or computer, I have a QR code that you can scan to do that. And I am going to send it to you post-event as well, just in case you didn't get it done. I'll send it to you probably in a week or two with the recording or the link to the recording of this symposium. So it's never too late to turn in a post-event survey. And again, I want to thank our sponsors. It truly means so much for them to be here and to sponsor events like this that benefit patients. And again, this is the reason why we can have these events and put them on for free for you guys. So thank you again, and thank you to UNC. And thank you. I hope you really enjoy the program today.
Okay. It's my pleasure to welcome Dr. Justin Yap and Cindy Rogers. We have a very unique program here at UNC. it's our parenting clinic because unfortunately we have some patients with children in the home. So Dr. Yap and Cindy's coming up.
Here's the back, forward, back, and then that's your, whatever,
Okay.
pointer.
Pointer, there we go. All right. All right, good afternoon, everyone. My name is Justin. This is Cindy, as Paula introduced us. And as Paula said, we're going to be talking about our Parenting with Cancer clinic. So who are we talking about? We're talking about mothers and fathers who have cancer, melanoma, any kind of cancer, and have children in the home. Why are we focused on that? Why do we have a clinic for these folks? One reason is because nearly one out of 5 cancer patients right now are parents, just as we described, parents with children at home. And sadly, that number is increasing as the average age of a cancer diagnosis is getting younger and younger. So parents with cancer are a sizable portion of the population and becoming an increasingly bigger one. And probably, as anyone can imagine, there is research to support this, but we probably don't need that research. If you are a mother and a father, or a father, and you have cancer, one of the first things you think about when you hear you have cancer, and you hear about your treatment, you hear about your prognosis, is about your children. And so for that reason, studies have shown that parents compared to similar age people who don't have cancer actually report and experience higher levels of anxiety. Parents with cancer describe not feeling like they know quite what they're doing, quite how to shepherd their children through this experience, how to talk to them, what to tell them, when to tell them, how to think about the future. We've had a couple of folks in our clinic who've said that it's a little bit like, much different, but a little bit like when you're a parent for the first time and you bring your child home from the hospital and you think, what the heck do I do now, right? Like, where's the manual? Where's the instructions of how to do this? And families report, of course, when someone has cancer and goes through treatment, the roles, the routines, the responsibilities within the home get really disrupted and get really thrown out of whack, which causes disruption within the home. And children are at higher risk for psychosocial distress if they have a parent with cancer. Thankfully, many children do just fine, but they are at a greater risk. So knowing all this, you know, this research, and this has been out there for a while, but it wasn't until Cindy and I in our work together, separately and then together, started to see parent after parent who really came to us with one of 2 questions before we started the clinic, right? These were kind of big bucket questions that parents came to us with their concerns. One is basically, how do I talk to my kids? Like I said, when do I tell them? How do I tell them? Do I tell them the truth? Do I kind of sugarcoat it? Am I honest? And really, how do I help them get through this, right? So being a parent during cancer is challenging and new. How do I do it? And the other one is, how do I make sure that my children and my family are okay if something happens to me, right? I think that's a question most people think and consider when they have a cancer diagnosis. And when you're a parent with young children who are dependent upon you, that question takes on even greater significance. So after a while of hearing these questions in my work as a psychologist and Cindy's work with patients and supporting them, we decided that we needed to just start a clinic. And instead of our other, our kind of psychology clinic that sees people, folks for anxiety or depression or general coping with cancer, we needed to lower the bar and have the criteria be just that you are a parent with cancer. That's the inclusion criteria to come in and talk to us and have a conversation. So we started this almost 3 years ago now, hard to believe for us. We do our clinics Wednesday afternoons. We allot 90 minutes to meet with parents. Parents meet with Cindy and I together for that initial visit so we can do the intake together as opposed to them having to tell us twice. And then we can kind of bounce off each other during the clinic visit with parents as we meet. We meet in person or via telehealth. Probably no surprise to anyone here, we see the majority of our folks via telehealth because it is just easier and more convenient. There is no charge. That is something we've been proud to be able to offer. We don't bill insurance. We don't have any kind of charge to come see us. Again, in the spirit of reducing barriers to having parents meet with us to have these conversations. We encourage co-parents, grandparents, anyone else to come that may be involved in raising the children More the merrier on that. And then a lot of folks follow up with me individually for psychotherapy or with Cindy for estate planning purposes, but that is done separately after our joint visit together. All right, so our clinic, it's a little more complex than this, but it really kind of falls down to having two broad aims, right? So again, first, we see parents at any point in their cancer experience, from diagnosis to just going through treatment to relapse, even into survivorship. Everything we talk about is important at all of these points. Ideally, we'd love to meet with people at diagnosis. It doesn't have to happen that way. It often doesn't. That would be ideal. But the two main broad aims are, one is in my bucket, one is in Cindy's bucket. My bucket as a psychologist is to talk with parents about how to communicate with their children, how to support their children, how to help navigate this experience as a family. And Cindy's bucket, she'll talk about in a minute. A little more about mine. My philosophy is I meet parents where they're at. I don't come heavy-handed with information. I don't come heavy-handed with you shoulds. This is the way you do it. This is how you ought to do it. Families are different. I'm not the expert on their children, right? The parents are. That said, there are certainly some tenets that I follow, and one of those is encouraging parents to be honest with their children. We have heard more than a few stories about parents who, understandably and trying to protect their children, are not honest, are not upfront. Children always find out. Children always know. Children have incredibly big ears. And so, almost without fail, being honest, being upfront, again, age-appropriate language, but being honest and upfront is the way to go. And I think almost every parent we meet with kind of knows that, like, yeah, I know, it's just really hard. And so we really walk through kind of the initial telling or the initial how to bring up the conversation in ways that are honest, are accurately reassuring, and do kind of facilitate this open back and forth communication. Because what parents and children are really doing during that first conversation and the subsequent conversations are establishing and maintaining trust around this issue, right? And if children can know that what mom or dad are telling me is pretty much what I need to know and pretty much the deal, that actually can reduce anxiety and can reduce that sense of I need to go on Google, or I need to put, my ear up to the door as mom and dad are talking in the bedroom, or I need to kind of be on the lookout for what's coming next. If the kids can feel like the parents are being upfront, helping them know what changes are coming, why they're coming, and that they can anticipate those changes, children do better. Parents generally feel less stressed because they're not having to hide as much. So even though I don't come heavy-handed with recommendations, that is certainly one that we get to all the time. And then from that point, it really just depends on the family situation, the dynamics, as to what my advice and my encouragement and my problem solving with the parents are. A lot of times I will see folks for psychotherapy following our first meeting, right? Sometimes that's around parenting issues. Sometimes it's just around nothing to do with parenting, but I have cancer and I'm stressed in all kinds of ways. So it ends up being somewhat of an entryway into psychotherapy for folks who are interested and may benefit from it, even as that's not the primary goal. All right, enough of me. Here you go, Cindy.
Okay, great. Hi. Okay. I'm Cindy Rogers. I'm an attorney by training. I've worked, though, in cancer support now for going on 15-ish years. And as Justin mentioned, we were both being called to meet with patients who were wanting to talk about health, communicating with their kids, and with having what I call future planning, but maybe rather late in their diagnosis, and maybe at a time when things were feeling more urgent. And Justin and I put our heads together after a number of these incidences and said, we need to do better. We can do better by trying to see people sooner, by at least introducing the idea of, in my case, estate planning. And estate planning is a very broad term. It includes a number of documents Number one that we talk about is advanced healthcare planning, and that's where we're asking somebody to name someone who's going to help them manage their healthcare decision-making if they're in a place where they're not able to do that themselves. We also talk about powers of attorney. We also talk about guardianship of children, and that can be included in a will or in a standalone document. Those are the focus of the estate planning portion of our clinic is really focused around education. And then if people want to move forward with preparing these documents, I help find resources for them to do that. Show of hands quickly, who in here has an estate plan? Y'all are way ahead of the curve. In America, adults, only about 60% of adults, 65% of adults do not have an estate plan. So around 30% do. So you can see that that's a need. Most people know they're important, but the barriers to getting that done, or even feeling like, oh, it's not time yet, I don't need that yet. You know, it's an easy thing to procrastinate. So part of our goal in this clinic is to introduce the idea to folks, provide them educational materials around the importance of these documents, and then when they're ready, to provide them a resource for helping to get them done. And Justin also mentioned that, you know, we meet with folks together and we learn about their stories together and the unique qualities of their family. And so in learning about them, we may also learn about other issues that are confronting the family. And some of the things that were talked about earlier by Diane Bensley in the financial toxicity session, you know, things about, are they worried about income? Are they worried about losing their job? Are they worried about their insurance? And those are all flags for us to know, to make sure to get them connected then back in with, say, a social worker, or, you know, giving them some guidance on how to tap what their rights are with regard to family medical leave and things like that. Whether or not they are eligible for COBRA if they lose their job. So these are all things that are meeting together and having a space that's dedicated to having a more open conversation about what their unique needs are, and this is what the clinic provides. And I think it's really helpful. We've been able to identify over the course of the 3 years families where domestic violence was an issue, and we're able to make referrals for them, where maybe that, or at least provide them some guidance and resources where they could reach out for help if they needed it. So, you know, I think that it was, in some of those cases, maybe an issue that would not have been discovered in the typical medical setting. So I'm really proud about that. So let's see. So as of March of this year, we've seen 185 families. 77% of those, of the patients whom we've seen were mothers. And they've been between the ages of 28 and 81. Now you may say, did we have an 81-year-old parent? Yes, but not with a minor child in the home. But we do see grandparents. And there are a number of grandparents out there who are raising their grandchildren, or at least in the home with their grandchildren, or perhaps are primary, secondary caregivers to their grandchildren. So we can offer support for them as well. 84% of the families had either 1 or 2 children, and we see all cancer types. We offer families a survey at the end of each of our appointments to provide us feedback on how we're doing and whether or not we're doing a good job, whether it's a needed service. The blue line indicates people thought we were very helpful, and the orange or brown line there is that we were helpful. And you can see in the area of communication, estate planning, and importance of issues, we did pretty well. and their overall experience was very good, and that everybody would recommend that this be a service offered. We were really, one of our goals, and we're still working on this, is to be able to see all of the parents who come into the cancer hospital with a cancer diagnosis. And so we're still working on that. So we, as Justin said, we want to have a really low bar as to how that happens, how they can get to us. And back to Justin.
Cindy is wonderful. She's also a little modest. And so I'm going to go back. That center line right there, that's really Cindy's, that center. Ugh. Yeah. The first one's mine. Mine's kind of the low-hanging fruit, right? All parents want to talk about how to support their children, right? I'm kind of giving them what they want. Cindy's part with estate planning, wills, guardianship, you know, we're only bringing that up because someone has cancer, and now there's a greater possibility that that's going to be more pressing issue than there was before. That's challenging, and the way that she navigates it, talks about it, and that parents respond to it tells us, one, that we're hitting on a nerve that has previously been unhit upon, and that tells me, and because I see it, that Cindy does a beautiful job with it. So you're welcome, Cindy. All right. Again, for those of you who are providers, please refer, email us, call us, put in. Paula's one of the best, which anyone who knows Paula comes as no surprise. Yeah. There's our website if you want to take a look. This real quick is because right now we are, as far as we know, the only psycho-legal clinic for parents with cancer in the whole country. I should have led with that. So as far as we know, we're the only one that does that. But we have created a website that's a whole team of us have been behind. You see there, Families Addressing Cancer Together. It is the only personalized, customized website that parents can go to, enter in their specific information, and through the algorithm that we created and worked on, get specific feedback based on their kind of cancer, their treatments they're receiving, their children's ages, their children's temperaments, prognostic factors such as that. So uncfact.org is that website. If you know anyone who may benefit, whether it's in Chapel Hill or in Boise, Idaho, this is going to be relevant. There's the website. Thank you all. Appreciate it.
I want to thank you for this. Just last week, my daughter lost her 41-year-old girlfriend up in Boston to a rare form of sarcoma, and they have an 8-year-old and a 6-year-old, and there was nothing like this. I mean, I was going to ask how common this is, and you answered the question, but thank you so much, because, boy, Carrie's family really could have used you.
Yeah, I'm sorry for your loss. There are some parenting with cancer clinics, but none that incorporate Cindy's piece. And we do have some services for bereaved parents, so maybe we can talk later. How about older children? Those that haven't launched yet? No. That might be a different clinic we need to talk about. Maybe I should join that one. We only see children, in part because this is has a legal side to it. We only work with parents. We pretty much only work with parents that have children under the age of 18.
And some special needs.
And special needs, if they're the guardian, yeah. But as the parent of a young adult children, I get it. So 18 is a legal threshold. That frontal lobe is still developing.
Thank you.
All right, thank you all.
Dr. Moskos. Happy to introduce our next speaker, Dr. Moskos. He's one of our medical oncologists here at UNC. If anyone has a passion for melanoma and science, it would be him. So really excited for his next talk. I think we touched on about you are what you eat kind of a thing. So get his slide up here. Is yours here? Here it is. Okay, there's a lanyard in front, back, and then the pointer.
Pointer?
Yeah, the green pointers.
Do I like this?
Yeah. Yep.
Oh,
it
okay.
is. And then, I don't know if you want the lanyard or.
This?
Yeah, if you want to walk around.
So I thank Paula and the organizing committee for doing this talk. I really asked myself to be self-invited for a conference, but this was the time that I felt that it was important for me to do this for you. This is a talk that started from you as patients, because you have asked us, me, many times, what can I do to improve my chances of being cured or improve my treatment? And this has been a question over and over for 20 years. And finally, I feel this kind of topic would be something of all interest. The topic is about diet, gut microbiome, how it affects the immune system, and the center part is cancer. But these are lifestyle factors that you can change the cancer, and you can put whatever you want. You can put diabetes there. I'm a person who has type 2 diabetes myself. You can change it, and you can put Alzheimer's disease. So this is affecting a lot of other things. So it is shocking to say that we're just are not by ourselves the way we define we are, like our normal human cells, that we are living with other things inside us. In fact, it's about the same number of cells that we, the human cells, are, plus the same number of cells that bacteria are inside us or on top of us. And I don't know how you define genes, because doctors keep talking to you about genes, but the way I define genes is like a surgeon. So we have Dr. Lila here. The more tools he has in his OR, the better he's going to do certain things. Or if you are an engineer or a car mechanic, the more tools you have, the better. So genes are tools that we have to do certain things. And as you can see, humans do not have a whole lot of genes. Actually, if we put all the bacteria together, we have more tools to do certain things. So we have bacteria all over our body, especially on surfaces where we are interacting with the environment. And this is simple. I need to change my. So this is simple arithmetic here. So I'm going to talk about density, so number of bacteria per ml. And also we're going to talk about volume. So I think you would appreciate, for example, that okay. You may appreciate, for example, that saliva up on upper right is a small volume overall, but it has a high density. Now, if you have dental plaques, the density of the bacteria in the dental plaque is equal to the density of bacteria that you have in the colon. We have a bright surgical oncology fellow, Kelly Hermans, who is particularly interested in the oral microbiome and how this may affect other things. But there is bacteria in the breast milk, there is bacteria in our lung, but the majority of the bacteria that we have, approximately 99% of them are in our colon, the large part of the bowel. There are bacteria in other parts of our body, in our liver or spleen, but we really do not know what do these mean. And bacteria are there for a reason, and you can see on the right side of the slide, they're doing things for us. Remember the genes that I talked about earlier, like they're doing things for us that we ourselves, our human cells, cannot do it for us. So they help us with a lot of things. One of the things they help us, and this is the kind of getting to the point of the story, is that we do not have enzymes to digest complex carbohydrates. So sugar is a monosaccharide, it has one sugar chain. So when we eat things like fiber, they have a lot of chains of sugars, one next to each other, but we do not have the enzymes to digest them. So when we eat that stuff, then they're largely undigested, and they're going through the way to the large bowel. And then a number of good things happen, maybe socially unacceptable, but actually they're so good for us. And this is a Google-generated AI figure. So eating lentils is actually a good thing, maybe socially not appropriate, because all these high fiber that lentils have, they go through our gut undigested, and it goes to the bacteria in our colon, and they do something good for us, as you will see. The next slide requires to sacrifice a slide here, which is a societal slide. Everybody in the room would ask, tell me one bacterium that I need to have in order to be better. Give me one substitute or something to take, and I'm going to feel better. But it doesn't go that way. There are lots of bacteria, and we need lots of bacteria to do certain things. Remember the gene function here. So I want you to understand that there are communities of bacteria, and the more complex the communities are, the better for us. So the analogy I personally use, and again, it's a slide that Google AI generated because I wanted to show the difference between a hunter-gatherer society, which has just a few members that are doing very mundane things, and they're more vulnerable to invaders and threats, versus a more complex society where we live in, where we have doctors, lawyers, we have maids, we have nurses, and other things. So the more complex the society, the more organized it is, and it can resist invaders. So this is a complicated paper that has a nice figure that I kind of pulled out and put it there. But what it shows here is that if you have a complex society of bacteria in your gut, you can resist an invader much better than if you have just a less complex bacteria in your gut, because the multiple bacteria that you have in your colon, if you have a complex microbiome, will be able to resist an invader of that sort. And this is another fancy pants paper to highlight how many broad substances a plant-based diet has, because there are so many multiple nutrients inside the plants that actually can form so many functions good for you, anti-inflammatory, resist bacteria that are toxic for you, because it's so rich and it feeds so many different bacteria in your gut microbiome. So this is another very instructive slide that, again, for the mathematicians in the room, I want to emphasize that this is a logarithmic scale, which means that, this is 10, but this is 100 and 400. So the numbers are much greater to show how certain food is more or less complex. So alcohol is not good for you, and probiotics are not good for you either. And in the middle, there are a number of different food substances that have differences in the complexity of the bacteria that we have. So ideally, if we could eat like raw food, it would be good, but we lack the taste, and therefore we have to ferment it to some extent. But in principle, non-fermented or slightly fermented food is better than drinking alcohol, perhaps, or probiotics. So these are 3 different types of diet that you as patients have asked many times. So all these diets, different types of diet, have shown to have a benefit. So you have the high fiber diet here, you have the calorie restriction, and the ketogenic diet. So all these things have actually good effects in the gut microbiome. But for the purpose of this talk and the data that we have right now, it's only the high fiber diet for which that we know very well through, as you see, questionnaire, retrospective studies, and prospective studies that have a benefit in our immune system and response in melanoma. So on the left side, this is a cross-section of how your large colon looks like if you eat lentils, and on the right side is a cross-section of your colon if you eat a lot of hamburgers. So On the left side, this is a colon that has your colon cells that are supposed to absorb stuff, and it has this nice mucin layer. And then on top of that, there are these good bacteria, and these good bacteria produce a lot of good things that are being absorbed and keep our immune system functioning. And on the right side, you have this thin out protective layer where now bad bacteria, the hamburger bacteria, as I call many times, my patients kind of get to know this, the bad bacteria overgrow, and then they produce substances that makes us have a low grade of toxicity. Remember yourselves when you eat a big burger or a big steak, like you feel like yucky after 2 to 3 hours after you eat that, you feel like you want to go to sleep. This is a low toxic state that you feel because endotoxins have been absorbed in your bloodstream and you feel like that. So it is the balance between this good and the bad bacteria that really is a daily matter. It's not like you just, once you develop that, it's like it stays there. You have to keep eating a regular diet to keep this balance in favor of a good gut microbiome. This is another very important slide because we as doctors tend to use these drugs all the time, but I cite a few of examples of common drugs that we use for heartburn or things that we eat when we eat processed food like emulsifiers or even opiates for pain that do have good or bad things in our gut microbiome. So when we take Protonics, it may be good for our heartburn, but what it does is break down this pH in our stomach, and therefore we have high acidity in our stomach to prevent a lot of bacteria from our mouth to go down to the large bowel. So we increase the pH, more things from the mouth entering the large bowel, and this may change our gut microbiome for the worse. And look at these emulsifiers. There are so many of them. They are in processed food, and what they do is they break down this mucin layer that is nice on those people who eat lentils, and they allow for bad bacteria to enter the bloodstream. And even opiates, what the opiates do, it's already the motility in the gut, in the lowest parts that is very slow. So you eat an opiate drug, and therefore it slows down further, and it allows for bad bacteria to grow further. And studies from the University of Chicago, actually, and I'm doing that in the clinic many times, is lactulose, a common drug that we use for constipation, has been shown to increase favorable bacteria species in your colon. So these are simple questionnaire studies in my previous university, at the University of Pittsburgh, where simple questionnaires were given to patients with melanoma on this side and non-small cell lung cancer. So the questionnaire was simple. Do you have a lot of sweeteners in your diet? And as you can see, if you have a high amount of sweeteners in your diet, the response to immunotherapies is lower. And in fact, people with sweeteners, they have a shorter progression-free survival to immunotherapies for both melanoma and non-small cell lung cancer. And so this is a slide that I first time saw in an immuno-oncology meeting in Paris in 2019, and almost I fell off my chair. That's another simple questionnaire study that researchers at the MD Anderson did in 2019, and the first presented in that conference, where basically what they showed in patients who were getting immunotherapies for melanoma, they were given a question as to whether you have a lot of probiotics in your food or not. And as you can see, there is not a whole lot of difference. But then there was a huge difference in patients who were having high fiber diet in their food versus low fiber. And the effect of high fiber diet was actually mitigated if you were getting high fiber diet and probiotics at the same time. And again, here we go again. We have a Google AI generated image because I couldn't find a good one. If you get probiotics, what you do is you decrease the complexity of your gut microbiome. The probiotics may help you digest the food, but actually they will override the amount of good bacteria that you have in the colon, and therefore that does not serve you very well. So we do not recommend using probiotics, commercial probiotics, especially when you get immunotherapies for your melanoma. Now, this is another questionnaire study where basically what they asked is whether you have high or low amount of omega-3 fatty acids in your diet, either as fish oil or you eat a lot of fish. And again, you can see that people who are consuming high amounts of omega-3 fatty acids, they were having high responses to immunotherapies in melanoma. As you can see here, the more complex your gut microbiome is, the higher the responses. Again, talking about the complex society that you have in your colon. And then here we have these good bacteria, which are called ruminobacteria, and then the bad bacteria, which are called the Bacteroides species. If you have good bacteria, it's inversely correlated with the bad bacteria, and it does correlate with high fiber intake and amount of omega-3 fatty acids. And what really shocked me is the differences in immunotherapy responses among different countries. So we have United States here, Netherlands, United States here, Netherlands, and Australia. And here's the good bacteria and the bad bacteria. And United States, usually in those patients who were enrolled in the study, had a higher frequency of bad bacteria in their colon, in contrast with Netherlands that had a higher frequency of good bacteria in their colon. And these patients, when they were receiving immunotherapy, simple immunotherapies before radical surgery, we call them neoadjuvant therapies, they had a higher responses, and which was different across different countries. And the investigators show this nice diagram, which is not good for us. It shows that how an average colon looks for an average patient in the United States, and how the colon looks like somebody who lives in Netherlands. And around the time I was preparing the talk, my wife had spent a week in Netherlands as part of a business trip. And when I showed that to her, she said, "I know what it is. Like every person in the Netherlands has a bike, and they eat like fruits and vegetables. That's why they're doing better than we do." I want to state this jargon that is not just medical jargon, but you guys deal with this all the time. So we need to understand what we're talking about here. When we talk about, so we have bacteria that is here, and then the prebiotics is the food for the bacteria. And then many times companies are preparing combination of probiotics with prebiotics together. And sometimes we may not care with who makes what. We care about the products of the bacteria that we're very interested in. You may have heard of a substance called inulin, which is inulin is a good a product of good bacteria. So this is very important to straighten this out. And we will only focus on prebiotics from now on. So what I just showed you was a bunch of questionnaire studies. And then MD Anderson, again, about a year ago, presented the first prospective interventional study. So can we actually increase the amount of high fiber in patients who are actually receiving immunotherapies for their melanoma? And whether this is feasible. So what they were doing is that they were preparing patients before they even start immunotherapy, and then they were increasing the amount of fiber. And this is just the common types of diets that patients who had a regular diet versus those who had high fiber diet. All feasible. The patients were randomized in this feasibility study 2-to-1 to receive high fiber versus regular diet. And the duration was 10 weeks, approximately the time that patients receive immunotherapies. And it was a small study, but it did show what it was supposed to show. That is that you're able to do this, and patients receive various types of PD-1 inhibitor-based treatments, alone or in combination with other immunotherapies. And what was shocking is in this prospective study now is that patients who had a high fiber diet, they had a higher frequency of immunotherapy responses. And another shocking thing was that the incidence of serious adverse events overall was lower in patients who were getting high fiber diet. And in particular, it was these skin toxicities, the rash, the pruritus, and for reasons that we don't understand. So we have a simple intervention like high fiber diet when you get your immunotherapy, and that leads to lower immune-mediated side effects. So in summary, should avoid artificial sweeteners, antibiotics. I didn't talk much about that. I didn't have time. Proton pump inhibitors and opiates. I'm not talking about absolutely avoiding them, but be more prudent when we use them, not abuse them, because they do have negative effects in our immunotherapy responses. And we should eat more fiber, fermented foods, Mediterranean diet, omega-3 fatty acids. So I'm going to close with 2 slides that have to do with your body weight and this GLP-1 agonist. So first things first, so obesity and diet are 2 different things. Obesity is a state. Diet is a dynamic thing that changes on a daily basis. And we have known for more than 10 years that people who are overweight, my BMI is 31, so overweight or obese people are doing better with immunotherapies and target therapies. This is the overweight, the obese, the overweight, and the normal weight, both for the target therapies as well as the immunotherapies. And they're doing better not because the gut microbiome is different. That tells you that it's the diet, it is this dynamic thing that you change over time, and not the obesity state that is more chronic that affects that. And more recently, there was this retrospective study, because a lot of people come to the clinic and they ask, if I get Mounjaro or I get Ozempic, do these things help my response to immunotherapy? And the answer is, they may do, but you have to wait for a long time to have any effect. So this is a retrospective analysis of a large number of patients who are receiving immunotherapies for melanoma versus just immunotherapies alone. These are very uncontrolled arms because these are retrospective studies and different groups, but you have to wait for a long time to really see any benefit. So the disclaimer for this talk is as follows, is that the impact of a high fiber, high omega-3 fatty acid intake of circular substitutes has been mainly studied for patients who are currently receiving immunotherapies. But you as patients need to ask yourselves, what can I do to prevent myself from having a relapse? We don't have data for this yet, but I do believe that probably in 5 to 10 years from now, it may be the exact same thing that actually made your response to immunotherapy better, maybe actually the reason why you keep yourself in relapse. And this talk may mean nothing to any of you who are actually doing all this. So it's more for those people who may be not doing that. Thank you.
Probably only have time for a few questions.
I was a little bit confused about the fermented foods. It seemed like the first slide you showed was that fermented foods are not good, and then another one, I've read about that they are good in general.
So ideally, it would be for people to eat non-fermented foods. But when you eat non-fermented foods, you sacrifice taste. So the process of fermentation is going to affect quite a bit of bacteria, but yet this is good enough and better than eating meat or eating alcohol or having probiotics.
Okay. It seemed like a recommendation on the last slide to eat fermented foods. I'm thinking of yogurt and fermented, vegetables and things like that.
Yes. So, but ideally, non-fermented food would be the best, but again, you sacrifice taste for convenience. And remember, this is something you have to do it supposedly every day. It's like eating good, eating properly is like a marathon. It's a lifetime change.
Definitely.
I understand your point.
So the other thing I wanted to just ask quickly is, microbiome, so much is written about it these days for a while, and is that something that's tested routinely in patients?
Yeah, so there are a lot of companies, there are spin-off companies that can offer this test for you. So you can submit your stool specimen, and it's like anything between $90 to $600 to do a narrow kind of check for certain bacteria of interest versus the whole shebang. So the question is standardization. So like there are different companies that offer these things, and how do you implement this in your everyday life? What does that mean?
So it's not really done in the healthcare setting at all?
We do not. Yeah, we do not, as part. If this is not part of a clinical trial, we usually don't do that. But I'll give you a tip here. Right now, there are certain bacteria that we consider as good bacteria that are actually being tested in a prospective clinical trial as to whether they improve immunotherapy responses. I didn't have time to go into that, but for example, there's one famous bug that's called Akkermansia muciniphilia. Patients who do not have Akkermansia muciniphilia in their stool are eligible for the study. That study is going on right now in France. So patients who are negative for the Akkermansia in their stools, they're on the study, they take Akkermansia, and they get immunotherapy at the same time. So now the question is whether the people who are Akkermansia negative and they get, A, whether they're colonized, B, whether they're improved responses.
Hello, I'm so glad we're talking about this. And you know, Mr. Mazurka, another European is thrilled about your presentation. Thank you. I want to talk to you about probiotics and prebiotics because, you know, I've had immunotherapy, lots of gut issues, still suffering with chronic colitis years after the immunotherapy. The GI docs say that will be lifelong. I will never get rid of that. So they've put me on some medication and enzymes and so forth. But they do recommend a probiotic and prebiotic all-in-one tablet. So I guess question number one is I need more clarity on why that's not good for me because I need to stop taking that immediately. And number two, is there collaboration between the oncologists that prescribe the immunotherapy and the GI department that's following immunotherapy patients that have the, as I call them, the unintended consequences of your treatment?
So it is a complicated answer. It is a very
I have a complicated question. I'm a complicated girl.
So Janet is a can I say? Janet is a champion, an amazing responder for very bad disease. And first thing I would ask Janet, I would have asked for Janet why Janet has done so well, is whether, here we go, whether your gut microbiome was very favorable from the beginning, and therefore that's why you had this amazing response. So you may have gone the other way around, okay? Now, maybe you have been so good, your gut microbiome, that I helped your response, and now they have to bring you somehow this way. But you're an exception, so we have not yet come to the level of doing individual patient-specific recommendations, because as she asked, it's not standard of care to actually test you for your gut microbiome before you actually get immunotherapy. So also gut microbiome, the good bacteria can be inherited. So there are some people who are doing well and we do not know why, and other people who do not do well. So it's not responsible to go out there and say, well, GI doctors recommend it because you have a dysmotility issue. We cannot go out there and give a blanket statement to everybody, start probiotics. I'm talking about the commercial probiotics through your milk, your yogurt, and all these things. So we are not there to give patient-specific recommendations yet.
Super interesting. Yeah, thank you so much. All right. Okay. I know we are running quite behind, but we are going to do our tumor board next, and then we'll take a break. So I'm going to invite our panel of experts, Dr. Morgan Gwynn. Are you still here? Yes. Dr. Moskows, Dr. Alrohil, and Dr. Harrisman. Come on up. And Claire, our research associate. Okay. Thank you. Great. And then if I want to go forward.
Forward and backward, and then that's your pointer.
Great.
And
Okay.
then, I don't know if you want that.
It was a great talk.
Should be enough. Okay. So often you may hear us say we're going to present your case at Tumor Board. Tumor Board is a terrible name for our multidisciplinary conference. Our melanoma team twice a month meets and discusses new patients and challenging patients, and many people from different disciplines come together in powwow. We have radiation oncology, radiology, pathology, medical oncology, research, and we all talk about patient care so we can better collaborate. So today we're going to discuss a case with our panel of experts. You know Dr. Moskows. Claire, can you introduce yourself, please?
Yeah, my name's Claire Kowalczyk. I'm one of the study coordinators for our melanoma group here at UNC. Hi, I'm Kelly Hermans. I'm one of the surgical oncology fellows here at UNC.
I'm Morgan Gwen. I'm the pharmacist. I've been with the group for about 8 years now.
And I'm Romeo Rahil. I'm a dermatopathologist at UNC.
Okay, and this is a real patient case which we have de-identified. We're going to do a little bit of time travel because this started in 2020. So this gentleman is a 51-year-old male. He's a father to 2 teenage boys and works as a manager in the auto industry. In January of 2020, he presented to dermatology with psoriasis and had been taking several topical treatments. He developed plaques upon his cheeks and scalp and temple and was diagnosed with pyoderma faciale. The key here is that he was treated with a long course of steroids for that dermatological entity. So 10 months later, after many, many months of steroids, he had a mole on his left groin that had become, quote, irritated, and this was biopsied. It turned out to be melanoma. So my first question is to the gang here, would this have happened if he didn't take steroids? Did steroids cause this melanoma to happen? Dr. Moskows, what do you think?
We know that skin cancers, kind of all of them, but some of them more than others, do have this special relation with the immune system. That is, if your immune system is somewhat compromised, you may have high likelihood to develop a cancer. But also it's very important to know that cancer doesn't just happen over a few months. This is a breeding process. This is a breeding process. A cancer takes several years to develop. So I would rather say it's a little bit of both. So he had the predisposition to develop that, and the fact that he got corticosteroids did not help the situation.
And if you think back to Dr. Ferris's presentation, you can see that we're in trouble here. We've got a very deep melanoma with a 6-millimeter Breslow thickness, a speedy melanoma. Remember, we like to see a mitotic rate of 0 or 1, and this was a 10. We have ulceration, and we also, some things could not be determined just on a biopsy. This was a shave biopsy, so we know that this is at least 6 millimeters. It could be deeper. So his stage, just on the tumor presentation, was a T4B, and the pathologist stained it and found that it was negative for BRAF. Dr. Alrohill, in a few slides down, is going to show us the actual slides of the pathology specimen, because we do save them for many, many years. People are quite surprised that we still have things. So we've got a T4B. What should we do next? I mean, are we worried enough that we should do some staging or scans? What do you think? Everybody says yes.
Yes.
What kind of scan would you recommend?
We would recommend a PET scan in this
PET
case.
scan. All right. Well, unfortunately, the PET scan was denied by insurance. All right. I need to.
Here, I'm going to just pop this off here. Yeah. In this type of melanoma at this depth, we would recommend a PET scan.
Can you hear me better now when I walk around? Great. Unfortunately, the insurance denied the PET scan, which is not uncommon. Insurance is not excited to pay so much money for a PET scan, especially when we have no evidence of spread yet. So we went ahead and did a CT of the chest, abdomen, and pelvis, which could capture all the necessary organs. We didn't see any metastases. So, Dr. Harrisman, what should we do next? Surgery?
So next step, in that we have ruled out any evidence of metastases, the next step would be surgery.
And what kind of surgery would you recommend?
I would recommend a wide local excision with at least 2 centimeter margins and sentinel lymph node biopsy.
And how did you come up with 2 centimeters? Why that?
So in deeper melanomas, we want to capture a larger margin. Because, as many of you know, melanoma not only grows down, but grows out as it spreads. So that's why the 2 centimeter recommendation.
All right. More worrisome news here. So we did the wide local excision. We did the sentinel lymph node biopsy. This was actually thicker than anticipated. Also, we did have some satellites here, which I should have highlighted in red. We had good clean margins. However, we had removed 3 lymph nodes, and all 3 showed melanoma. So that put him at a stage 3. There's stage 3A, B, C, and D. So should we go ahead and take out the rest of the lymph nodes? That seems to make sense. I mean, we know that 3 of them have melanoma. Why don't we just take out the rest?
So historically, that's what we did. But trials have shown us, specifically the MSLT2 trial, that there is more morbidity when you do this in the age of immunotherapy. So that is our next step. And we surveil these patients to see if there's any type of nodal recurrence moving forward.
So don't take out the rest of the lymph nodes. Okay.
Correct.
Can I say something?
Yes, of course. I thought that's...
So I've gotten old enough to know that when we started the fellowship like 25 years ago, it was like a response rate was just fading out as an important endpoint. And as we advance our therapies in cancers in general, the standards of what is considered acceptable are getting higher and higher. So we want cancer patients, if we're going to do something to a cancer patients, our goals are to make them live longer and with less morbidity. So whatever we do to them, we have to be mindful of that. So if an intervention like a lymph node dissection adds up morbidity and does not make people live longer, that's a problem. So making people live longer is a big deal.
And Dr. Alrohill, can you come up, because we've got slides both from the initial biopsy and the lymph node.
Okay.
This green button is the pointer.
Hey, hello everyone. So it's a rare thing for you to see a pathologist, so you're laying your eyes on a pathologist here. So our role, we're behind the scenes. We're usually the ones that look at your cases and give the diagnosis. And our role is not only diagnosing the disease, it's also helping in giving those parameters like the Breslow thickness that we talk about, the adverse events like mitotic activity, vascular invasion, microscopic satellites. In melanoma specifically, these are things that we evaluate in order to help the rest of the team to decide what is the next point and what to do for the patient. There are many cases that the excision, only an excision is done, and there's no need for sentinel lymph nodes. Those are for the T1A usually cases, so it's just an excision and that's mainly the treatment, versus advanced cases like this where it's T4B and N1 or N1, N2, N3. So I'll go through a little bit through these details of what does that mean and how do we see it under the microscope. So what we're seeing over here is a skin excision, and we're seeing on this side, this is normal skin, and this big nodule over here is the melanoma cells. Now, there are many tumors that occur in the skin, so a dermatopathologist doesn't only look at melanoma. We look at all types of skin cancers, all types of inflammatory disorders. So you need skills and training in order for you to recognize what kind of cell that we're looking at. Sometimes it's even difficult to tell what's the cell that we're looking at, so we do immunostains, so things that tell us what protein these cells are expressing in order for us to know what are we actually looking at to give you the right diagnosis, to help the clinical team to do the best management for you in taking care of you. So when we're looking at this case, the first thing that we would do is measure the Breslow thickness, which basically is the thickness of the tumor. So it's the most from the top layer of the skin surface to the deepest aspect of the tumor, and this one is a 9 millimeter thick melanoma. Just for you to have a perspective of it, 9 millimeters is almost like stacking 9 quarters on top of each other. So that's like how the thickness of a 9 millimeter, usually a quarter is like a 1 millimeter, if you still see quarters these days. The other thing that we assess in these cases is we tend to look at the skin surface and how is the skin surface reacting to this melanoma. So on closer inspection, when we look over here, this is all melanoma. All these cells that are filling the dermis are all melanoma cells. Here on the side, we have an intact epidermis, so the skin surface is intact. But here on the other side, we see an area where the skin surface is gone, and this is ulceration. Now, why does that matter? It's because ulceration is an adverse event that we assess in melanomas, and it tends to carry a worse prognosis, and we usually see it in higher stages melanoma. We rarely see that in T1 melanoma. We tend to see ulceration to occur usually in T2, T3, and T4 melanomas. Next parameter that we look at is what do the cells look like? Are the cells looking small and monotonous in their appearance? Are they looking atypical? So here we see, when I say atypical, it's like you see a cell that's really large, a cell that's medium, a cell that's small. So that's pleomorphism and atypia, and we look at the mitotic activity, which is the replication of the tumor cells. And that, again, is another adverse event that we tend to assess in melanomas. We look for lymphovascular invasion, the presence of invasion of melanoma cells in the vessels. We look for perineural invasion, which is entrapment of the nerves by the melanoma cells. We look at the host response, is their immune system response against the melanoma. So these are things that we evaluate in the case. Now, so I showed you the first slide that was like where the main excision is, but we don't, so when Dr. Olila takes that big chunk of skin that's being excised, we don't only evaluate the tumor itself, we evaluate almost the entire sample, because one thing that we look for carefully is this phenomena. So if you look over here, this is the epidermis, the skin surface. This is the dermis, and we see these two areas within the dermis. Those are what we call microscopic satellites. So microscopic satellites are basically where the melanoma can spread away from the main. So you look at the tumor, we're seeing it. Everyone in the room who would look at it like, yes, we're seeing it. Those microscopic satellites, the only one who can see them is me under the microscope. So we look at it, when we assess for your melanoma, we're not only just looking at the tumor, we're looking at all the surrounding soft tissue that got excised to catch these if they're present, because those tend to upstage your melanoma. Similar to how a lymph node metastasis is, this one affects the staging from that perspective, not the T stage. So we talk about the T stage for the tumor size, the N stage is for the node status. But in melanoma, we also have these microscopic satellites that affect the end stage in melanoma when we look at these cases. So this is a satellite that we had. There were multiple satellites in this case that we were able to identify in this excision. And as mentioned earlier, that's why the wider margins are taken, not just like the melanoma where it was. We take the surrounding soft tissue to assess for the presence of these and to get a negative margin around them. Lastly, as mentioned, lymph node, there was 3 lymph nodes that were taken, and we found, so this is lymph node tissue, this is normal lymph node, and here the lymph node tissue is occupied by all this metastatic melanoma that's occupying it, and that was, like the largest focus was 16 millimeter, which is a fairly sized metastasis. So these were our pathologic findings. The depth was 9 millimeter with ulceration, multiple microscopic satellites, the metastatic melanoma to 3 out of 3 lymph nodes. That's how we can give you that it's T4B and 2C, and that is where we get the clinical state. Because without those, you can't generate what the final path, the tumor clinical staging is. So so our role comes to provide the most accurate clinical stage that the melanoma has. Do you want me to go through the molecular? Yeah, so we mentioned that we did the BRAF immunostain on this case. So BRAF immunostain is basically a screening tool. It's the main mutation that we look for in melanoma for possibility of using a BRAF targeted therapy. So those, but for a more comprehensive assessment for the mutations that are present, we can send tissue for molecular testing. The main place that currently at UNC where we send the samples to is a laboratory called Tempus. We mainly look for the mutational profile that the tumor has. We look for the tumor mutational burden. We see if anything that can also be helping with the targeting therapy to be used in some patients. Sometimes that BRAF immunostain is not as sensitive as the molecular assay, so there are cases that are rare where the BRAF immunostain is negative, but actually the molecular results will show that there is a BRAF. Sometimes it's a variant of the BRAF, so there's a specific one that we usually look for is V600E. Sometimes there's V600K. This immunostain is not really good at detecting it. It's better detected by molecular assay. So in this case specifically, there was no BRAF mutation, but there was a TERT promoter. It did harbor also the CDKN2A, CDKN2B, and the MTAP copy number loss. So that was the main findings that we had in this case from a molecular perspective. And the reason we send it for this is it will help Dr. Moskos decide what kind of therapies can be approached and what to do in the case. Of course, thank you.
Thank you. All right, so then the insurance was happy to pay for a PET scan, and we also did a brain MRI because a PET scan, even though it goes head to toe, does not capture well what's in the brain. Thankfully, we didn't see any distant metastases. We talked about taking out or not taking out the other lymph nodes in the groin. So, immunotherapy. We talked about, this is a stage 3. Should we just do one immunotherapy? Are we allowed to do 2 different immunotherapies? Dr. Moskos, what are the rules for stage 3?
Can you go back to the molecular? So we have passed, we are now about 15 years into the fancy pants molecular information. So we get this thing and we go like, what are we gonna do with it? If you would ask me 10 years ago, I would tell you that this is really, sounds really bad. But in the era of immunotherapy, that does not really mean a whole lot, because although it looks like that these are a bad set of mutations, patients can really respond to immunotherapy. These mutations provide the medical oncologist an opportunity to try to identify whether any drugs for that. Well, guess what? There's nothing to really target. So what I'm going to do with this information? So it kind of looks bad, but over the last 10 years, with all these great advances with immunotherapy, we are actually more hopeful than what that looked like 10 years ago. So it's very important for patients to know that this is not the end of the world.
So Dr. Moskos, is there a role for 2 different immunotherapies together, or do we just do a single agent for stage 3 melanoma?
Okay.
In 2020.
After surgery.
So, okay, so we have to understand how drugs are approved, and the way that they're approved is based on the inherent weakness of the scans. The scans are not as sensitive as what the pathologist is gonna tell you in 9 millimeters, I can see something. We have a problem with the scans. The resolution is relatively small, so the way the drugs have been approved is on the basis of what these patients will end up doing without any treatment 2 or 3 or 4 or 5 years from now. So that's very important. So now we have a patient that does not have any evidence of scan positivity. So the trials have been done, and a patient who have a stage 3C melanoma is eligible for an immunotherapy. So we spend at least 10 years to figure out whether we're gonna do 2 immunotherapies versus 1 immunotherapy. But basically, right now, if we give 2 immunotherapies, and I talk about ipilimumab plus nivolumab, because that's what has been officially been out there and tested, there has not been an improvement compared to giving 1 immunotherapy. So 1 immunotherapy is what is available for this patient. The question is, the way I see an immunotherapy in 2026 is like when I start giving this analogy when patient comes to the clinic. It's like having dollars in your pocket. Do you want to use the dollars in your pocket because the FDA and your health insurance is giving you this opportunity? Do you want to use them right now, or because you're allowed to do that, or you save them for later?
Well, this gentleman did get pembrolizumab or Keytruda for 3 cycles, 3 doses, and he had pretty significant side effects, a lot of fatigue, some blurred vision, and his kidney function was unhappy. But in the middle of all this, we had a new small pimple appear next to the scar. Sorry, that should say scar. And we did an FNA, we did a fine needle aspirate of that lesion, and it showed that there was a local recurrence or an in-transit recurrence of the melanoma right next to the scar. So we're like, oh dear, well if it's recurred here, could it have recurred elsewhere? So we did another scan, we did a CT of the chest, abdomen, and pelvis, plus another brain MRI. Things were still fine, so we had a local recurrence. At that point, we sent off Tempest, which Dr. Alrohill has explained. Dr. Hammer, would you go and re-excise there? What do you think we should do next?
Sorry. I think that you could do multiple options for local control. Certainly you could re-excise, or, we have started to implement TVEC in our patients for more local control.
So for this patient, we did a local treatment called Limogene Laparvovec.
Thank you for not making me
TVEC.
say that.
And it is a herpes virus that invades the cancer. Right? The mic is not working? Okay. I'm trying to project. It is a herpes virus that also stimulates the immune system to the scene of the crime. And he had some severe flu-like symptoms from that medication. So going along, it was time for another scan, because we scan pretty much every 3 months. And he had new and enlarged nodes in the groin. So even despite our best efforts with immunotherapy, we had a recurrence, or progression of disease, I should say. We did another brain MRI, which was normal, and now what? So should we look at clinical trials, or should we look at maybe doing 2 immunotherapies together? Claire, just thinking about clinical trials, I know that was 2020, but pretend it was now. He had nephritis, so that's a side effect. He did not need steroids. Does he have do we have any trials that have anything for that TERT mutation, or any clinical targeted trials?
We don't have any targeted trials. The only targeted trial we have is for our NRAS mutant patients, and that was one of the pertinent negatives that did come up on the Tempest report for our targeted trials.
Okay. So we decided we're going to get out some more weapons. We're going to do, instead immunotherapy, which clearly was not sufficient, we were going to take 2 immunotherapies, kind of 2 different military regimens, the Army and the Navy. We were going to do ipilimumab and nivolumab. But the question is, what dosing should we do? Traditionally, it was 3 milligrams per kilogram of ipi plus 1 milligram per kilogram of nivo. Or do we flip the dose, which has showed lower toxicity? Panel of experts, what do you think? Morgan, do you have any feedback on side effect profiles or efficacy?
So side effect wise, we know that when we give ipilimumab, it has what we call dose-dependent toxicities. So the more dose you give, the higher the risk for getting a side effect. But that's not true for nivolumab. You can give bigger doses, and technically the data shows that you do not have a higher risk of toxicities. And so for a patient like this who had a toxicity for just one immunotherapy, you worry about getting more and more serious side effects when you give 2, right? But he also has that history of psoriasis, so it also has an autoimmune condition which could potentially increase your risk. And so for those reasons, and knowing he doesn't have cancer in the brain, it would probably be a safer option with probably similar efficacy to do the ipilimumab at the 1 milligram dose.
That's what we did. All right. So after 1 cycle, he developed a cough. After 2 cycles, he had increased cough and shortness of breath, and it was COVID time. COVID was negative. He developed pneumonitis. How frequent or rare is that? Do you have any data, Dr. Gwynn or Dr. Moskowitz, on pneumonitis as a side effect? We know anything can get inflamed, but how often does this occur?
What? You want me to answer? I don't have the exact instance, but it is considered a more rare side effect. I think it's less than 5% is the total risk. It's higher when you give 2 immunotherapies compared to 1. And so for this patient, would not be totally unexpected after he'd had side effects to 1 to have had this happen.
So we could not do any more immunotherapy, and he had to be on prednisone for many, many months. We stopped the prednisone because his symptoms resolved. When we stopped it, he had a recurrence of pneumonitis, so he needed to do prednisone plus mycophenolate. And Dr. Gwynn, what is mycophenolate? Like, what is that traditionally? I thought it was for organ transplants. What are we doing with it here?
Yeah, so what we're finding is these side effects happen because your immune system is not as regulated as we would normally want. We've done something to help stimulate your immune system against the cancer, but it then gets stimulated against normal parts of the body sometimes, and in this instance going against the lungs. And so when the steroids, which are supposed to help suppress your immune system, aren't enough, we add a stronger immunosuppressant like mycophenolate to help it out.
What happened to that melanoma? Thankfully, even with 2 cycles of ipi-nivo, there was significant improvement in his scans, and he's had no evidence of cancer since 2021, so almost 5 years. I have a question, though. Let's say, knock on wood, he recurred. Dr. Moskowitz, would you feel comfortable offering immunotherapy again?
Yeah, so people need to understand, because we overuse and abuse the word immunotherapy. What we're talking about is a particular type of drugs that have been available, and these are called immune checkpoint inhibitors. So we should be more disciplined to use the word immunotherapy, immune checkpoint inhibitor type of immunotherapy, because there are other ways to stimulate there are multiple ways to stimulate the immune system. TVAC, for example, is another way to do that. So perhaps if he would relapse like now, he cannot receive a PD-1 inhibitor type therapy, because the possibility that he's going to have what we call recall, his immune system will remember how to attack his lungs, is going to be very, very high. In fact, any patient who develops pneumonitis is not a good idea to give PD-1 inhibitors. So this is where you start thinking about other ways to stimulate the immune system, and there are, and now we are in this era of
cellular therapy. So somehow we get immune cells from this patient's body and we do something to them and then we give it back to him.
Paula, real quick. I think our decision tree, it was clinical trials and more immunotherapy. I think the other thing that should have been kind of part of that dialogue is that we need to weigh the risks and benefits of completion nodal dissection. Because if it truly was just recurrence in the nodes, then nodal dissection should be on the table for that. But of course, the risk with that comes with its own morbidities.
Thank you. Excellent point. So he continues to see dermatology every 3 months. Now he's down to scans annually. And he still becomes anxious as scan time approaches, and I think many of my patients can empathize with scanxiety. And he's very grateful to our team. And I picked Popeye, and forget about the smoking pipe, but I remember when I was growing up, Popeye had a tattoo, and do you remember it would get very animated when he was putting up his muscle, and this gentleman actually has some arm tattoos, and he incorporated his care team into his tattoo. So he's very happy. Any questions? Thank you for hanging. Oh, yes, Ms.
So you mentioned that the panel meets, was it bi-monthly?
Second and fourth Wednesday of the month.
So how far do they, I mean, that patient from beginning to end, I mean, are they constantly looking at that patient? What is that projected?
Yep, so I mean, automatically any new patient gets on the agenda, but every time I send out the agenda or I talk, anybody can nominate somebody to be on the agenda. So often when we have a bump in the road or a recurrence, that patient gets back on the agenda for discussion. Dr. Yap?
And since this was a father with two teenage daughters, he would be referred to the parenting.
If we were in 2026, he definitely would have been, so thank you. Yes?
Does tumor board ever discuss clinical trials that are not being conducted at UNC?
Could you repeat that, please?
Does tumor board ever discuss clinical trials that are not being conducted at UNC as potential treatment pathways?
Yes.
The patient himself is asked routinely whether they are willing to travel to other places in the country for that. It has become less frequent because there are so many treatments. We have like 3 or 4 line treatments before we talk about clinical trials afterwards. But yes, if the patient is telling us that they are willing to travel, yes, we would do that.
Okay.